फोटो नहीं आ रही।
तारिणी मैम और कीर्ति दुबे मैम से बात हो गई है, वो लोग भी ज्वाइन कर रहे हैं मैम।
तो क्या आपने सबको म्यूट कर दिया है?
हेलो जी,
हेलो उषा मैम, नमस्ते नमस्ते।
हेलो तारिणी, नमस्ते।
अब सबको म्यूट कर दें जब तुम शुरू करो।
रंजीत जी सबको आप म्यूट कर दीजिएगा शुरू करने के टाइम। अभी देखो पूरी देर यार लो बैंड विचेस।
Good evening to all. This is Ranjit Sahu. Welcome you all to this UPCOG Oncology Committee invites you for a live webinar on World Cancer Day. The topic for the webinar is Gestational Trophoblastic Neoplasia, Controversies, Challenges and Concern. And there is a very beautiful topic on the eve of World Cancer Day we have chosen. And we have eminent doctors across the country, specifically from UP, are there to discuss upon and deliberate. So with this, I hand over the session to Divya ma'am. Dr. Divya Diveji, she is Assistant Professor from GSVM Medical College, Kanpur. With this, over to you, Divya ma'am, to take it forward. Divya ma'am, it is all you.
Thank you, Dr. Vishal. Namaskar to all the dignitaries and delegates present here. I, Dr. Divya Divedi, Assistant Professor, Obs and Gynae, welcome you all in the webinar on Gestational Trophoblastic Neoplasia organized by UPCOG or UPCOG Oncology Committee on World Cancer Day. Before beginning this program, I want to seek the blessing of Lord Ganesha. I request you all to kindly join the hands. Vakratund Mahakay Surkoti Samaprabha Nirvighnam Kuru Me Deva Sarvakareshu Sarvada. Today we have gathered online on the theme of to celebrate the theme of World Cancer Day 2022, which is Close the Care Gap, and simultaneously to strengthen the motto of UPCOG Oncology Committee, which is very well expressed by these lines. चाहे ये बीमारी नहीं महामारी है, चाहे ये बीमारी नहीं महामारी है, फिर भी जीतने की जिद कैंसर पर भारी है. And for this जीतने की जिद, I invite the convener of the program, Chairperson Oncology Committee, a very refined surgeon and academician, Dr. Kiran Pandey ma'am, to give her welcome address. Ma'am, please.
Thank you, Divya, for very kind words. Namaskar. Good evening to all respected, honorable, and distinguished faculties and esteemed delegates. I welcome you all on the occasion of World Cancer Day on behalf of UPCOG Oncology Committee in this great academic feast with the theme of Gestational Trophoblastic Neoplasias, Controversies, Challenges, and Consensus. World Cancer Day year 2022 is being celebrated with the theme of Close the Care Gap, so that every single one of us has the ability to make a difference, large or small, and that together we can make real progress in reducing the global impact of cancer. I want to, before I welcome everybody, I want to say pay my great regards and thanks to Usha ji for giving me this responsibility of Oncology Committee. Madam, I'm very thankful to you. I want to pay regards to our very honored, respected Dr. Raj Baveja ji, though she's physically not present today, but her blessings and support is always with us. She was not well, and unfortunately, some incidents has happened. Her niece is no more, so she was very upset and said, I will not be able to join. I would welcome our Chief Patron, Padam Shri, Dr. Usha Sharma ji, our patron, Dr. Chandravati ma'am, and Dr. Meera Agnihotri ma'am, who has not yet joined, maybe she's busy somewhere. They are our mentor of mentors, teacher of teachers, always giving us guiding the blessings. They are the guiding force behind all of us, motivating us to strive for better and better. I would also like to welcome all the pillars of UPCOG, Dr. Tarini Taneja, President, a very good friend, a very kind-hearted person. Dr. Kirti Dubey, a wonderful, magnificent persona, a great friend. Dr. Bharti Maheshwari, a very charming personality and very down-to-earth person, continuously working for the upliftment of the UPCOG without tiring any time. I also like to welcome our dear friend, Dr. Saroj Singh, President UP Agoi, and Dr. Nisha Singh, who has probably not joined yet, as she's little unwell. Secretary UP Agoi.
I'm here.
Okay.
Good evening,
so welcome, Nisha. Dr. Saroj and Dr. Nisha are our pillars of UP Agoi and again working for the cancer. I would also like to welcome Dr. Urmila Singh. She is my dearest of the junior and a very dear cooperative friend, and she will be moderating along with me this panel. I would also like to welcome our star-studded panelists, Dr. Kanchan Sharma, Secretary Cox, Dr. Amrita Sarkari from Gorakhpur, Dr. Pragati Agrawal, Dr. Meenakshi Sood, Dr. Shelly, Dr. Niharika Mehrotra, Dr. Priyanka Garg, Dr. Mamta Singh for this interesting panel. But the last and the most important person, our participants, our delegates, without whom, and even I am expecting that our PGs will also be there and will take the benefit of this less talked cancer and the neoplasias about which we are going to discuss today. With this short welcome address, because I be more interested in taking the blessings of our seniors than my saying anything about cancer, I would like to stop and request Dr. Divya to carry forward and invite our Padamshri, Dr. Usha ji, our chief patron.
Thanks, ma'am, for your kind words. Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurur Sakshat Param Brahma, Tasmai Shri Gurave Namah. Now, to seek the blessing of Ishwar Tulya all Gurus, firstly, I request Teacher of Teachers, Padma Shri Dr. Usha Sharma ma'am, who is ex-Director General, ex-Director General, Medical Education, Uttar Pradesh. She was Principal cum Professor of Gynecology and Obstetrics, LLRM Medical College, Meerut. Lifetime Chief Patron of UP Chapter of Obs and Gynae Society and Patron of Meerut Obs and Gynae Society. From the Best Medical Girl Award of India in 1965.
बस सबको पता है ये, अब तो लोगों को रट गया होगा बहुत कुछ, हम सबका तो है. चंद्रा जी.
To the Padma Shri Award in 1985, she has many feathers in her cap. Ma'am, I request you to bless us.
चंद्रा जी, आपकी साउंड ठीक नहीं है. मेरी साउंड ठीक आ रही है?
जी मैम, आपकी सही आ रही है. मैम
आपकी चंद्रा जी टूट रही है बीच में.
हाँ मैम, नेट का इशू है. आपकी बहुत अच्छी आ रही है.
हाँ,
हमारे यहाँ तो बारिश हो रही है ना.
जी मैडम,
बारिश हो रही है वहाँ।
हाँ हाँ, वो बता रही थी अभी उर्मिला।
बहुत तेज
Thank you.
बारिश है।
Thank you very much, Pavika, for saying such beautiful and I
Ma'am
can say
Divya.
attractive words.
दिव्या, हाँ।
And first of all, I would like to just remember our respected advisor, Dr. Raj Baveja. I know due to the death of Anurita, she is very much disturbed. And for the last 2 times, she is not able to join us. And then certainly our great leader and affectionate supporter, Dr. Chandravati. And I'm really missing Meera. She has not joined yet. Then our dynamic President UPCOG, Dr. Tarni Taneja, Secretary Dr. Kirti, and Joint Secretary cum Treasurer Dr. Bharti Maheshwari. Then the heroine of the day, Dr. Kiran Pandey, who is the chairperson of Oncology Committee, as well as her whole team. We all know that Kiran is also contesting for chairperson Medical Education Committee, as well as Kanchan for Breast Committee. And I'm sure that all of us will certainly support them because they are from UP and we want to come to Foxy like this. And then we have moderator with us. Again, Kiran is the moderator and Dr. Urmila Singh, expert Dr. Saroj Singh and Dr. Nisha, though Dr. Nisha was not well, but thank you, Nisha, that you have joined our webinar today. And then names have already been taken by Kiran, the most worthy and learned panelist we have with us today. Then Master of Ceremony, my dear Pavika and Divya. And then I will not forget the representatives, Ranjit and Feroz from Water and Emotional, who have given the technical support this webinar. And today, Kiran, you have really selected a very important and recent upcoming gynecologic cancer, that is gestational trophoblastic neoplasia, controversies, challenges, and its concerns. We all know that we have been dealing with molar pregnancy since ages. And not only this, we are also talking about the follow-up of molar pregnancy with beta SCG. Now, it has almost been confirmed that the incidence of persistent gestational trophoblastic disease, which has now been taken the name of gestational trophoblastic neoplasia, is increased. The incidence has increased and it is about 50% in the cases after molar pregnancy and about 25% in cases after abortion and ectopic and 25% after term and preterm pregnancies. And we have to know each and everything about these things so that we can treat them well. Foxy and WHO have come up with the standard staging as well as the prognostic criteria and the prognostic scoring of these diseases, which all of us know should very well, so that we do not let this disease grow to carcinoma or progress to advanced metastasis. With these words, I will like to congratulate Dr. Kiran Pandey and her whole team for this selecting this wonderful topic. And I'm sure that the deliberation today will go a long way in updating the knowledge of this very important upcoming subject, and everybody will be benefited greatly with this. Before I finish, first of all, I just wanted to just converse for our dear Dr. Kiran Pandey and Dr. Kanchan Sharma, as they are contesting for Medical Education Committee as well as Breast Committee. And then I will like to tell you all and request you all with folded hands to please join 33rd Annual Conference of UPCOG, which will be organized at Meerut on 11th, 12th, and 13th. Due to clash of few dates, we have just reversed the thing. On 11th and 12th, we are having the conference proper, and on 13th, we are going to have post-Congress workshop. And please join in large numbers, because your presence will give us great encouragement as well as make this event a memorable one. So thank you very much. We have also started one thing that we had some discounted membership, life membership before, which was 3,000, but then we finished and stopped it. But again, we had opened it to have that the few postgraduates may like to send papers and they have to be member. So the persons who will register themselves and they want to be new members, they can have discounted new member subscription, that is 3,000 rupees. And I will request you, all the faculties and all the delegates who are present here, to be with us, give us chance to give you a good academic event as well as a good social, whatever we can do. और हम चाहेंगे कि हम सब मिलके वहाँ खूब मस्ती करें, खूब पढ़ें और खूब नाचें कूदें. So all of you are invited to UPCOG 2022 on 11th, 12th, and 13th of March. With these words, I really congratulate Kiran and her team for organizing this webinar. Thank you very much.
थैंक यू ईशा जी, थैंक यू थैंक यू थैंक यू. आपने इतने प्यारे वर्ड्स में हम लोग को आशीर्वाद दे दिया. आपके आशीर्वाद से पूरी उम्मीद है कि हम लोग अच्छे से करेंगे. कंचन इज डूइंग ऑलरेडी लॉट्स ऑफ वर्क and I will also try my best, madam, and we'll be there in the march definitely, madam.
Sure,
with जी मैडम, बस एक थी, there was a, I've just came to see that Dr. Reena Srivastava has also joined our past president. So madam, welcome to this webinar. Divya, please go ahead.
And now I invite very respectful, compassionate, diligent Dr. Chandravati ma'am, who is patron of UPCOG and Professor Emeritus King George Middle College, Lucknow. She is Director, Krishna Medical Center, Lucknow. And
Divya,
जी मैम
बस
ठीक है
मैं ये कह रही हूँ,
Usha always makes my work so easy because वो पहले से सब बता देती, मुझे कुछ बोलने का जरूरत ही नहीं पड़ती. चाहे वो यूपीसीओजी की इनॉग्रेशन हो, चाहे मैं यहाँ हूँ, तो सब काम वो हल्का कर देती है. पर मैं
आप ही से सीखती हूँ.
हाँ,
आप ही से सीखती हूँ.
तो बस बढ़िया है ना, जब कर दिया काम सब मेरा आधा करके बड़े लोगों को छुट्टी दो तो आराम से. But my main aim is today is, of course, I always join all the UPCOG because I love to be there. I love to meet each and everyone. My special message today is, as Usha said, that I want to bless Kiran and Kanchan, and Kiran has opted for a very important
medical education.
Medical education, and a person coming from that background who's already looking after the medical education. I think it will be a wonderful help to Foxy if she becomes a chairperson of the medical education. So my blessings is there, and for Kanchan also. I'm sure both of them would be coming out with the flyful colors, and we will have the happy news. Thank you, Kiran, for
thank you, madam. Thank
applying
you,
for
madam.
it, and thank you for your wonderful topic today for gestation diabetes. So for this topic, I've told all my residents also to sit down and listen, because this is something very important, and one likes to know the controversies, likes to know where we can go wrong, likes to know what we should not do and what we should do. Because in UP, we do not have that many cases of molar pregnancy as you would find in Kerala and South, some places. But still, if even 1 or 2 cases are there who are for follow-up, they keep you all the time worrying how to see the follow-up and how to see the end result of this, so they do not end up into choriocarcinoma. So far, I don't think any of us, I think very rarely we have allowed anyone to reach to the stage of choriocarcinoma. Our patients have done well with our follow-up, but it would be wonderful for all the delegates who have joined today to listen to this. Your panelists are wonderful. I'm sure this session is going to be very, very wonderful. And I do not want to take too much time because you can start a scientific session. We anxiously want to listen to the moderator and the panelist. Again, God bless you, Kiran, for organizing this.
Thank you.
And all the chairpersons of UPCOG, Usha, I think they are doing wonderful job.
Very good.
They make us sit, but at the same time, they are really doing hard work for all the chairpersons.
That's true. They are really working very hard to make these webinars so successful and actually very, very academic and beneficial. And thank you very much, Kiran. Actually, till now, Chandra ji, एक talk होती थी, एक panel discussion होता था.
पैनल में मजा आता है.
2 घंटे से ज्यादा हो जाता था, तो बैठने में कभी-कभी हम जैसे बुढ़ों
लगता है हम लोग उठने लगते हैं. हाँ. पर आज ये रखा तो.
हाँ, तो मैंने किरण से ये कहा सिर्फ पैनल करो, क्योंकि पैनल में तुम ज्यादा रखो पैनलिस्ट, and then you can touch each and every aspect of the subject. Thank you, Kiran, and I think it will be followed in future also.
मैडम, आप हम लोग तो जो आप कहते हैं उसी पे चलेंगे, तभी हमें पता है सफलता मिलेगी. बिल्कुल.
So much, ma'am, उषा मैम और चंद्रावती मैम, आप लोगों का विश्वास हम लोगों के लिए blessings है.
बस.
Thank you, ma'am.
So much for nice words.
Ma'am has not joined yet. She might be joining shortly.
Ji and Dr. Chandravati ma'am, thank you so much for your blessings.
My blessing there. Thank you.
Thank you so much.
Now I am pleased to invite very dynamic and passionate President of UPCOG, Dr. Tarini Taneja ma'am, who is a senior gynecologist and IVF specialist, chairperson of ISAR Delhi, having keen interest in research related to PRP. Ma'am, kindly shower your blessings on us.
Thank you so much. Is it Bhavika or
Divya? Divya.
Okay, Divya. Looking very vibrant in the red. And thank you so much for your kind words and good start with the blessing of Ganesha. So first of all, today is a very pleasant day, little bit drizzling and barsat जैसे कहना चाहिए हल्की हल्की हो रही है. So my greetings to all the respected, my seniors, my colleagues, friends and juniors, and my especially heartfelt greetings to our Ma'am Raj Baveja ji. She is not here, and our Padma Shri Chief Patron Dr. Usha ma'am, ever smiling, the support of the all guiding force of each and every webinar with the Dr. Chandra ma'am. Chandra ma'am is also ever present in all the webinar, and she really boosts our moral. So she is really, she's an icon of the infertility for us. And now I think Dr. Meera ma'am is not there. Dr. Reena, our past president, my senior, she is there. My greetings to her also. And to the dynamic secretary, Dr. Kirti Dubey, and joint secretary cum president, Dr. Bharti Maheshwari. And the convener for today, yes, ma'am ne kaha, heroine for today, Dr. Kiran Pandey. Really, she has made the really utility of this day, Cancer Awareness Day. And she has chosen a very, very important subject, very less discussed, usually in the conference also. So it's a very useful and fruitful to all our delegates and to the PG, and definitely for all our clinicians. And expert, always the good expert, Dr. Saroj Singh and Dr. Nisha Singh. Dr. Nisha Singh, how are you? Get well soon. And co-moderator is Dr. Urmila Singh. And our panelists are very, very active and dynamic. They are holding so many posts, president, secretary, everybody is president, secretary here. So like Kanchan Sharma is there. And my all best wishes, Dr. Kanchan, to you. Then the Amrita, Meenakshi Sood, and Pragati Agrawal, Priyanka Gaur, Mamta Singh, and Shelly Agrawal, and Niharika. And our Master of Ceremony, Pavika, and Divya, you, Dwivedi, and also the platform provider, Walter Bushna. Ma'am, I would like to say definitely you have given the extend the platform, academic platform of UPCOG with your vision. And thank you so much, Dr. Usha ma'am, Dr. Chandra ma'am, because the academic curve is taking high of UPCOGians, because everybody is getting motivated, and also we are able to familiar with so many members of so many societies. So really many thanks. You have increased the horizon of the UPCOG in academics, and everybody is getting going high and high. And really, I wish everybody should come in the flying cars, Kanchan and Dr. Kiran. Dr. Kiran, I think nobody is against you. I think you are the unopposed till now.
नहीं हमारे अगेंस्ट 3 लोग और हैं.
Oh my God. So topic.
हम लोग को एक ही एग्जाम याद रखना है.
You will come, कोई भी हो, सर जानने की जरूरत नहीं है. So the full support of the UPCOG also from the India. So you should do, messaging and also the phone call personal to everyone. So about the cancer awareness is for the cancer prevention awareness is very important, especially for the cervical cancer and breast cancer. And breast cancer is leading cause in many metro cities. So it needs a very much awareness. So early detection is the complete cure. And this for this gestational trophoblastic neoplasia, I think the doctors have to be aware, because he is not the concern with the patient. Whenever the patient comes with the continuous bleeding PV or developing the respiratory or neurological symptoms, we should think about that, and we should do the beta HCG. That's a non-invasive test just to rule out the choriocarcinoma. And especially when the patient is very young, below the 17 years, or it is a elderly patient above 35 years. And the Asian ethnicity is also very important. And Dr. Chandra ma'am has told us the follow-up is also very important. And to confirm the diagnosis, histopathology is important. So we would like to listen in the panel to what we should do in this placental origin malignant tumors. What we should not do, we should not do the clinical biopsy in the vascular mode. So we would like to listen and refresh our knowledge and enrich the knowledge. So thank you so much, Dr. Kiran, for inviting for this important academic session.
Thank you.
And thank you, Usha ma'am, and thank you, Chandra ma'am, for increasing our academic responsibilities. So it's going so well, taking high.
Our chairpersons are responsible for that, not we.
Yeah, ma'am, you shoulder the responsibility.
They are really working very hard.
Ma'am, just because
I appreciate their efforts.
Yeah,
ma'am, vision तो आपकी है. Vision आपकी है.
Vision आपका, you shoulder the responsibility as a chairperson to them. Only then we are able to do that. So it is your and Dr. Chandra ma'am's vision. Just because of that, UP is rising now. Everywhere is UP. Okay.
Thank you, ma'am. Now I invite a very good orator, teacher par excellence, and a good human being, Dr. Kirti Dubey, ma'am, Secretary General UPCOG, who is head of the department and professor in NCR Institute of Medical Science, Meerut. She is president of Meerut Option Gynae Society. And in the limited resource setting of government hospital, her interest in infertility and high-risk pregnancy has helped thousands of patients in their struggle to achieve their dream of parenthood come true.
Oh, thank you, Divya. It's enough. It's enough. Good evening, madam. Good evening, madam. Good evening, Chandra ji. Good evening, our president, Dr. Tarni. And a very warm namaskar, I would say, in such a weather to Kiran and all my colleagues. And of course, Kiran, this is really very nice of you to cover such a topic of GTN. And what we have to understand is that's not only the management of the benign trophoblastic diseases, it is a real follow-up of these patients so that they do not end up into catastrophe. A very nice day for this webinar, and I wish you all the best. And we believe we are going to really refresh, as Dr. Tarni has said, we are going to refresh our knowledge by the newer panelists which are coming up, and they would add something to what we know. Thank you so much.
Sure. Thank you.
It's my pleasure to invite very energetic, enthusiastic, thoughtful Dr. Bharti Maheshwari, ma'am. She is Joint
evening, everyone.
Secretary
Good
and
evening.
Treasurer of
Dr.
UPCOG.
Divya, just a minute, just to interrupt. Dr. Idmani कह रही है मुझे link नहीं मिला. She wants the link of the webinar.
Ma'am, I have sent her the webinar ID right now.
कौन?
Dr. Idnani.
अच्छा,
मैंने अभी भेजा webinar ID. फिर भी आप
चल ये बायोडेटा हटा दो, भारती को बोलने दो.
हाँ, good evening.
भेज रही हूँ उनको.
Good evening, everyone. Namaskar. And respected Chief Patron, Usha ma'am, Chandravati madam, and all office bearer. And of course, all seniors has already said everything. And we are eagerly waiting to attend this webinar and this panel.
Yes.
But I just wanted to use this opportunity to invite all of you for the UP chapter conference going to be held at Meerut. And we are really eagerly waiting to welcome you all. So all of you, please come and give us opportunity for hospitality of you. Thank you very much.
भारती कहाँ जा रहे हैं आप?
लौट रही हूँ.
नहीं, मैं कॉलेज से लौट रही हूँ.
कीर्ति कितने दिन के बाद आपको देखा है? डॉक्टर कीर्ति, how are you? डॉक्टर कीर्ति?
हाँ, hello, I'm fine.
कितने दिन के बाद आपको देखा है? You're so busy in your work.
Thank you, ma'am. Now I invite my colleague, very hardworking, dedicated for academics and gynae oncology, Dr. Pavika Lal, Assistant Professor, GSV Middle College, Kanpur, for taking you to a very interesting scientific session in form of a panel discussion on GTN. Now it's over to you, Dr. Pavika.
Thank you so much, Divya ma'am, for the kind introduction. मेरा सभी को सादर नमस्कार और सभी को प्रणाम बड़े लोगों को. Today, on the eve of World Cancer Day, it is important to recognize the power of knowledge. And so to begin the scientific session on GTN, controversies, challenges, and consensus, I would like to welcome our very own Dr. Kiran Pandey ma'am. I just want to express her motto is to work for a cause and not for applause. Live life to express, but not to impress. Ma'am will be moderating the panel. Next, I would like to invite Dr. Urmila Singh ma'am. She has been a great teacher with a phenomenal perfection, and she will be co-moderating with Kiran Pandey ma'am. I would also like to welcome our experts, Saroj Singh ma'am, Professor and HOD, SN Medical College, Agra, President UP Agoi, having a very sweet and modest persona, and Nisha Singh ma'am, Professor KGMC Lucknow. She is also Secretary UP Agoi, a very energetic and dynamic personality with recipient of many awards, and she is doing great work in oncology. Then I would also welcome my all celestial and ingenious panelists. Sorry, I want to be very crisp in introducing everyone, so I will be naming only everyone. Dr. Pragati Agarwal ma'am, Secretary Bareilly Obs and Gynae Society. Dr. Kanchan Sharma ma'am, Secretary Obs and Gynae Society. Meenakshi Sood ma'am, Secretary Aligarh Obs and Gynae Society. Amrita Sarkari ma'am, President Gorakhpur Obs and Gynae Society. And Shelly Agarwal ma'am, Professor at GSPM Medical College, Kanpur. She is an ever charming and sagacious persona. Niharika Malhotra ma'am, she is a consultant at Rainbow Hospital, Agra, a very vibrant young face of Foxy. Priyanka Garg ma'am, Secretary of Gynae Society, Meerut, a very magnetic personality and a great laparoscopic surgeon. And last but not the least, sorry, Mamta Singh, Secretary Varanasi of Gynae Society, Associate Professor at IMS BHU. So welcome all panelists. Over to you, ma'am.
Thank you, Pavika. I know you wanted to save the time, so you have introduced our panelists in a very crisp manner. But that's really great because we all know they are the post holders, president and secretaries of different societies. So I welcome all my panelists, and let's start with the session. Ranjit ji, I'll share my screen. So.
Yes, ma'am.
Please do the needful, ma'am.
Yeah. Are you able to see my screen?
Yes, ma'am, it is perfectly fine.
Yes.
Okay, just let me check. Is it moving?
Yes, ma'am, it is moving.
Okay. So thank you very much. I, along with Urmila, we welcome all our esteemed panelists to this panel discussion on the gestational trophoblastic neoplasia. As everybody has said, it's a little less discussed topic. When we were residents, we used to always read about hydatiform mole. And I mean, it used to fascinate us कि वो अंगूर के गुच्छे जैसे bleeding में निकलते हैं. We always remember that, मतलब उससे हमेशा उसका वो एक perception hydatiform mole का वहीं से बनता था. But so much has changed that nomenclature has changed, the newer concepts have come. So I thought of discussing this, and I'm happy that my seniors agree with this and they like it. Urmila will be discussing with me. So we have already welcomed our panelists. I don't know, has anyone not joined till yet? Niharika has been able, Mamta has been able to join or not? Just Divya or Pavika, check and let us know. So just to introduce basically a little, yes. Gestational trophoblastic disease, it is a heterogeneous group of interrelated lesions that arise from abnormal proliferation of placental trophoblasts. Now there is a group of diseases, it is not one. So incidence of GTD, as said already, varies with the region, and higher incidence is there in Asia compared to Europe and North America. And even in India, as Dr. Chandravati was saying, the more common in the Kerala and other places compared to northern region, but still we see many patients. And in today, the two cases in which I have kept third and fourth case, they are my own cases where we found this little different presentation, so I wanted to discuss. Now, hydatiform mole encompasses almost 80% of all GTD, but invasive mole also accounts for 15%, and choreo and rare types 5%. Cure rates with advanced treatment, with the knowledge today which has come to us, is almost approaching 100%, and treatment typically allows for fertility preservation also. Now, basically, I have taken all this from NCCN guidelines, so we will follow them accordingly. Just to give you a little brief before we start with the case, GTD there can be divided into benign and malignant. And benign, as we were reading always, partial mole and complete mole. Whereas in the malignant, the new entity has come, that is ITT, intermediate trophoblastic tumor. And out of this also, there are two: epithelioid trophoblastic tumor and placental site trophoblastic tumors. So these is a newer entity. Invasive male, and of course, choriocarcinoma, you have all heard about it. So let's, I think, Urmila, would you like to start with the case one?
Yes.
You keep telling me, I'll do the slide change.
Thank you, Kiranji. First of all, good evening to all faculty members and everyone. And my great regards to Ushaji and Chandraji, my great teacher. And welcome to all our esteemed panelists. So I'm going to start case one. Mrs. X, 29 years, gravida 2 para 1+0, presented with amenorrhea of 3.5 months and often on bleeding PV with passage of fleshy mass. Her ultrasound picture showing snowstorm appearance suggestive of H mole. Dr. Pragati, are you there?
Yes, ma'am.
How will you proceed this case further?
Yes, ma'am. This is a clear-cut case of hydatiform mole, and I will do a per-abdominal examination to see for the fundal height, and then PV examination also, whether the os is open or closed. And then I will do some investigations like CBC, blood group. If it is blood group will be positive, then she may need Rh NTD, and then thyroid test and that kidney renal function test, liver function test. These all will be done. Serum electrolytes, And then the most important is beta SCG. That should be done, and also chest X-ray. It should also be done to see for any metastasis if this is malignant, or to exclude its metastasis.
Yeah, very well said, Dr. Pragati.
And I will
so whenever
ma'am, I will also counsel the patient that it needs proper follow-up. It may be malignant. It may, even if it is benign, then it may turn into malignancy. Therefore, a proper follow-up is very important in this case. This I will counsel the patient first, and then I will proceed for the management.
So very rightly said. Whenever the patient comes with the ultrasound report, there is the H-mole is there. Always examine the patient by general examination and physical examination, per abdominal and per speculum examination, usually for the secondaries in the vagina and how much bleeding is there. And along with that, the baseline investigation is very important. You said very rightly. Now,
Dr. Urmila, can I add one thing?
Yes, Doctor. Dr. Saroj, you are the expert. You have to guide.
I just want to add that when we are doing evacuation of a molar case, when we were students, we used to start oxytocin drip on one hand and then that has to be avoided.
Saroj, abhi will come to that, I think.
Abhi aur aayega question.
Hai na?
Okay, to prevent embolization. That
you will have to give us the final word.
So one is the baseline investigation is the must. Now what are the differentiating feature of partial mole and complete mole? Dr. Meenakshi, are you there? Dr. Meenakshi Sood? I think she's not there.
No.
Anybody can?
Yes,
she's there.
Yes, Madam Namaskar. If you recognize me.
Namaskar.
Yes. My warm regards to all my seniors and hello to all. I would like to first tell that between the differentiating features of partial and complete mole, we can do by clinical and cytogenetics. If we talk of cytogenetics, then the most important differentiating feature is that an empty ovum is being fertilized by 2 sperms. And in complete, that is the complete mole. And in a partial mole, the egg is normal. It carries 23 eggs, but it is fertilized by 2 sperms. So it becomes 69 XX or 69 XY. Now, clinically, if we know, then partial mole usually has an embryonic feature. It has an embryonic element, so it would present as missed abortion, while complete mole would be like a molar gestation. Uterine size in partial mole is usually smaller or the same average, and in complete mole it is larger, around 50% larger. Thecal uterine cysts are rare in partial mole, while they are 15 to 20% in complete mole. And medical complications are very rare in partial mole, while in complete mole, usually there are the medical complications. Post-molar malignant sequelae is just less than 5% in partial mole, while it is 6 to 32% in complete mole. So if we see the pathology, fetus is usually present in partial mole, while it is absent. There's a complete absence of embryonic element. Amnion fetal sac usually present, and that's absent. Villus edema is variable and it is focal, while it is totally diffuse. As we say, the complete mole is snowstorm appearance. And trophoblastic proliferation is also focal. That is why the villus edema is also focal, while it is diffuse and severe incomplete, as there is no embryonic element. As I said, karyotype in partial mole is 69 XXX or 69 XXY, while in complete mole it is 46 XX or 46 XY, because the maternal ovum is usually empty. So by these we can always differentiate these two things.
Thank you, Dr. Meenakshi. Very rightly said. You can differentiate by the clinical examination, by investigation, and by karyotyping. You can differentiate between the partial mole and complete mole.
Ma'am, may I add something?
Yes.
Ma'am,
Sure.
in the pathology, one thing is important that with the partial mole, we can see a bit of normal placenta also in the partial mole. But we won't be finding any normal placenta in the complete mole.
So
Yes,
there's the villus edema is focal in case of partial mole, and it is the diffuse in the complete mole.
I think so. The basic idea for differentiation is that malignant potential is very important. So that is our future thing. Like in complete, the chances of malignant sequelae is more compared to partial. So the management are also according to that.
So the next question, what is the line of management and what precaution must be taken? Dr. Kanchan.
Thank you. First of all, I greet
Dr. Urmila.
and I am overwhelmed.
Before you go to this topic, because we were differentiating, I just wanted to add that importance of differentiation before you take up the patient for the procedure is important. Pathological report will not be available at that time. So therefore, by the clinical and the sonological features, we should have this idea. It's just important. That's why I wanted to highlight. So that because if it is a partial mole, the procedure for evacuation, and if it is a complete mole, then there might be, so that has to be kept in mind at that time.
Very right. Very right. Right.
Very right. Thank you, ma'am. First of all, I want to greet the stars of UPCOG, Dr. Usha Sharma ma'am, Dr. Chandravati ma'am, Dr. Kirti Dubey, Dr. Tarni ma'am, and Dr. Maheshwari, Dr. Arun, Dr. Kiran Pandey ma'am, who have given me chance and make a part of it. Thank you very much for making me a part and showering blessings on me. Thank you. Then coming on the question, what is the line of management and the precautions to be taken? Of course, when we see that this is a gestational trophoblastic disease, now that we have diagnosed it and done the baseline investigations, baseline SCG and baseline even X-ray test, as you have advised for this, whether there is a metastasis or not. The line of action is suction and evacuation, of course, after the basic beta SCG. But please keep in mind that do not start oxytocin in drip, because that may increase the chances of pulmonary embolism. You may add oxytocin near the end of the procedure. Just for the contraction. Counseling is very important in these all cases, because we have to counsel to our patient about that you may have bleeding later on, you may have subinvolution because of herediform mole. If you do the curettage, there are more chances of even rupture of the uterus perforation. So you advise only the suction and evacuation. And next thing, we have to advise to the patient that you have to come for the frequent follow-up, which is very important after the suction and evacuation. Because if you follow by the beta SCG levels, which are to be done weekly initially and later on the monthly basis, if 3 back-to-back weekly.
Kanchan follow up का case question बाद में है. Let us understand clearly.
So thank you.
Ma'am, can I add something?
If it is RH negative, you have to give.
One point which has been missed here. Even suction evacuation has to be done under general anesthesia, ma'am. The anesthesia is also very, very important in these cases, which has not been mentioned.
So ideally the suction evacuation.
Importance is that one hand you keep on the fundus, because just to regulate your procedure, and second sharp curettage should not be done, and histological sample should be kept.
No. So ideally the suction evacuation and curettage should be done ultrasound guided. Ideally is the if it is done with the ultrasound guided, then the chances of perforation is less. And the oxytocin should be started at the onset of evacuation to prevent the hemorrhage and the perforation. And because there's the chances, if the uterus is large, the chances of bleeding is more. If the uterus is more than 16 weeks size, always arrange 1 unit of the blood. If the patient is RH negative, simultaneously at the time of the procedure, you can give the NTD.
NTD,
yeah.
Ma'am, NTD for all complete moles also?
For complete mole, usually we avoid NTD.
Yeah, because the fetus is not there.
But you have to give.
Very right.
Ma'am, but curettage should be avoided. Even
curettage first, it is suction evacuation and curettage, not by the sharp curettage, by the suction cannula. You can do the curettage simultaneously.
Actually, Pragati,
because
there was
a
Pragati, initially there was this curettage should not be done. There has been this is a controversial point actually. Many a times this has been the protocols have changed. But what presently the NOVAC and the guidelines, NCCN guidelines say that the end of the procedure, as Urmila is saying very rightly, that by the suction cannula itself, you do a gentle sharp curettage. Because what the reason is, the last tissue which comes out is most important for histopathological examination. So
this is what I wanted to tell Kiran. That the last tissue what you take out by the curettage should be sent for histopathology, which is very, very important. So gentle curettage at the end of the procedure, once you find the uterus has contracted, there's no bleeding, very carefully, as Urmila said, ultrasound guided, you can do a gentle curettage and send the tissue.
Yes,
so it is needed and the oxytocin should be started because you need
oxytocin should be started in between, not in the starting of the procedure.
No, at the onset of the because uterus needs to be contracted.
Yes,
because this is written.
Thank you, Chandraji, for your valuable.
Okay, the chances of hemorrhage are more in the beginning because it's a huge size. That's why Dr. Urmila said more than 16. So hemorrhage and bleeding is more in the beginning. That's why you need it in the beginning. Later, once that is out, it starts contracting gradually. So over the years, we have been using this, but because there were episodes of patients going into, embolism, that's why this about continuing for a longer time and, towards the later part, things went off. That's it.
Actually, this question, I mean, this was a controversial. Many controversies are there.
Yes, ma'am. There is a controversy.
Thank you for your expertise.
But Dr. Chandravati madam has said very rightly, and she has given her opinion. That's correct about the curettage and oxytocin. Also, we are using starting from the very beginning. And Saroj, you also wanted to say something.
I just want to say that oxytocin, preferably, if we can avoid, if size is not very big, we can avoid it. If it is very big, then we may start it for preventing the excessive hemorrhage. But if it is very small, it is better if we can skip it.
Small uterus, you do not need that much.
We don't give.
16, 18 weeks, 18, 20, 22 week size.
24
week size, sometimes they come. So sometimes they come with very big uterus.
And then of course, secondly, the things which we use for priming, like mesoprost or prostate, that also should be avoided in these cases.
Yes, because otherwise sudden hemorrhage will be there.
Never.
That should not be done. That should not be done.
So very rightly, all our experts have finally solved the controversies almost, I think, for all practitioners.
Madam, can I add one thing?
Yes.
There was a point why NTD is given because we are saving the future pregnancies. It is not given for this pregnancy. The embryonic element may not be here, but then the patient will plan in future. For that, we are giving NTD.
No, ma'am, but in this, the fetus is not there. That means RH antigen has not been expressed.
Fetal RBCs are also not there.
RBCs are not there, and they don't go to
So
the
no
maternal
RH
circulation.
expression has been there. Yeah.
These are the controversies. But
So the
but the
point of,
guideline says that you have to give.
so
But
Dr.
if the
Urmila,
guidelines say it's okay.
yeah, I'll tell
Okay.
you. I'll tell you
Sometimes,
why.
you know, what happens,
Just a minute.
Kiran, what has happened is that while you are doing it, many times you are not sure it is partial mole or complete mole.
Absolutely.
Yes,
That's
yes,
what I was saying.
Still your
Absolutely.
histopathology types
Yeah.
comes and all that.
The
You cannot give
histopath
it.
will come later.
Give it. Yes.
Better to give.
Give it.
Yes.
Better to give.
It
Better to give.
It is
Doesn't
better to
matter,
give.
yeah.
It is better
Yeah.
to give. Yes.
That's the result.
Yes, so that is the right advice, very right, Chandraji, Ushaji, that we don't know at the time of evacuation what is happening, so it's better to give. So let us, I think now the points into everybody's minds, these are clear. Is good, Urmila, you have brought out this point. Okay.
So the next is the follow-up between partial mole and H mole is different. Dr. Amrita? Doctor?
No, ma'am. Follow-up is the same. Although the partial moles are at lower risk of malignancy, there are less chances of malignancy in cases of partial mole, but still we follow up in the same manner. That is, we regularly monitor the HCG levels, and HCG levels should go down 3 weeks consecutively. They should be going lower, and by the end of 63 days, they should be very low or in negligible amount. But if we find a plateau for 3 consecutive weeks, then we consider something is wrong with that. Or if we again start finding a rising level of HCG for 2 weeks, that is 3 consecutive times we find a rise, then also we consider there is a risk. So we follow the patients, like we regularly follow them up weekly till the levels go down, and then monthly checkup is required up to 6 months, and then after 6 months it is 3 monthly. We by the end of the year, if the patient is normal, then we lose the follow-up. If we don't find any malignancy, we can stop the follow-up. But if we find it as a high-risk case, then the further follow-up is required, and ultrasound is also required for such patients.
Thank you, Dr. Amrita. So the follow-up is the same in the partial mole and the complete mole. Weekly till it becomes normal. Use 3 consecutive values are normal. Usually it comes in the 56 days. And it is said, in literature shows that if it comes normal after 56 days, there is the risk of GTN in latter part of the life in these type of the cases. So the NCCN guideline says after 3 consecutive normal value, you do the only 2 SCG value at an interval of 3 months. But we do the monthly for the 6 months.
Yes, ma'am.
Thank you. So the Dr. Pragati, in what percentage of cases does the complete and partial mole may have metastatic potential after evacuation?
Ma'am, this is the potential for metastatic potential or for GTN? That is for malignancy.
Metastatic potential.
Okay. For metastatic potential, it is 4% in a complete mole, and in other types of mole, it is very infrequent.
So the metastatic potential in the complete mole is 4%, and in other type it is very rare. After molar evacuation, GTN may exhibit histological feature of H mole and choriocarcinoma or ITT. But there is some entities after normal pregnancy, abortion, ectopic pregnancy, GTN always has histological pattern of choriocarcinoma or intermediate trophoblastic tumor. So there is the risk of metastasis is the 4% in cases of the H mole. Next.
Dr. Urmila, I just had a little doubt on this. Don't we have around 15 to 20% risk of?
That is 15 to 20% is for the GTN. For the GTN.
Yeah.
Not for metastasis.
Yeah.
You are asking about
Metastatic. That is the lung.
Okay.
Lungs.
Because the GTN in the partial mole it is less than 5%, and in complete mole it is 15 to 20%. Okay, that is for the GTN.
Yeah.
Yes.
Should I move it?
Yeah.
Next. So what is the role of prophylactic chemotherapy after evacuation of H mole? Dr. Kanchan. Dr. Kanchan, this question is for you.
Ma'am, actually, there is no role of prophylactic chemotherapy after evacuation of H mole in a normal case, but we have to counsel the patient and tell that in case you have to come for follow-up, and in case you develop there is SCG, beta SCG, which is too high and that doesn't come normal, then you have to come to us and we have to start
Yes, ma'am.
chemotherapy.
Ma'am, may I add something?
Ma'am, risk. Yeah.
Ma'am, may I add something?
Yeah.
If ma'am, may I add something?
Yeah.
Ma'am, if beta HCG is too high, that is more than 1 lakh, then there is definitely a role. And if we find theca lutein cyst on ultrasound, then definitely we consider the levels to be high, and then there is definitely a role. If the uterus is larger than normal, then also we consider the prophylactic use of chemotherapy. And also if we consider that the patient will not come for follow-up, or if she is not willing, which is already written, then also, and if what I talked about the follow-up, that plateau part, if the levels are not going down and they are staying to a level for 3 consecutive weeks, then also we need to give
not the prophylactic.
That is not prophylactic.
That is not
prophylactic.
Ma'am, can I?
Yeah.
That is not prophylactic.
It is okay.
That is not prophylactic.
Yeah, ma'am, there is a risk stratification index for this. Like we have mentioned that this factor is very important, that beta HCG is too high in the beginning, the uterus is large, but there are certain other high risk factors in which we believe that the patient might develop GTN, and these are actually the age of the patient, previous pregnancies. Then other ma'am, there is actually a grading system for deciding whether this is low risk, patient, high risk. Hello.
Yeah. We can hear you, Priyanka.
Oh, thank
There
you.
is a FIGO classification. FIGO
No,
risk
that is for
and-
GTN.
No,
ma'am.
not the FIGO.
That is later on, ma'am. This is only you want to give prophylactic chemotherapy or not. Like we have just done evacuation. Abhi kuch follow up nahi kiya. Still, we believe that this patient should be put on prophylactic chemotherapy. Then there is another risk stratification system for that. And we need to find those high risk factors. If we feel, then we can give prophylactic chemotherapy also.
Dr. Priyanka very rightly said, these are comes in the high risk factor of the post-molar GTN. The age is more than 40, beta HCG more than 1 lakh, corpus luteal cysts are more than 6 centimeter, uterus size is large. So these are the cases for the prophylactic chemotherapy. And the factor, it is also indicated when the beta HCG is too high and the patient is not compliant, she is not willing for the follow-up. In that case, you can give the single-agent chemotherapy, either actinomycin D or methotrexate. It is recommended. Thank you, Dr.
Urmila.
Yeah.
I would like to really comment on this point.
Yes, sure.
Very important. Very important. Because whenever we do any case, we treat molar pregnancy, and then we have to counsel the patient that it is very important to go for the serial beta HCG levels. And if we do not have the facility ourselves, we must refer the patient to a place where it can be done properly. And if it is a persistent value or plateauing value, or it is a rising value,
that is
definitely make see, because when we give these messages that in this you can give prophylactic,
routinely it should not be given.
let me complete, Dr. Urmila. I know what you are saying, what you have written. You know, these 1 or 2 lines are there at places, but when we are on such forums and we are giving recommendations, we should understand a patient who cannot follow up with the beta HCG levels. How can you leave her on a chemotherapy that you just give prophylactically and you do not monitor what is happening to her? So I really feel, I mean, though, you know, 1 or 2 points are there where they say, like, see your first point, beta HCG is too high and assessment of HCG is unavailable or unreliable. Then you talked about not willing to follow up or high risk factors. If there is a high risk factor, then we better diagnose and treat it, and we treat it properly. It's very important because that's the point I want to make, that let us not leave it lightly. Follow up, diagnose and treat it.
Counseling is the must. First point is the
very
counseling.
important.
I agree with Dr. Nisha Singh. Yeah.
Yes,
very
counseling
right.
is the very must. Routinely, it is not indicated, and this is for only the, because initially it was said the GTN is the treatment of ourselves, not for the cancer. Am I audible? Please mute yourself.
Urmila, you people are, somebody is, I mean, by mistake has unmuted.
So I am talking about the literature.
सब लोग अपने को म्यूट कर ले, बहुत आवाज आ रही है बीच में.
This is says the literature, but ideally it is should not, prophylactic should not be given. If the patient should be counseled for the follow up at least for the 1 year, for the beta HCG, all the risk of GTN and malignancy should be explained. And in rarest condition, if she is not willing or she is not coming, बार बार आपके पास ही आ रही है, नहीं जा रही है कहीं, then what you will do in those cases?
Urmila, you have said rightly. Nisha's point is also good, but what I will also feel, sometimes how much you counsel, कभी-कभी ये situation भी आती है. So you have to keep, I mean, एक customize करना है हर patient के हिसाब से, you have to follow. Ideal
नहीं आ रही है तो क्या करना है?
हाँ, ऐसे rare cases में कभी-कभी ये भी होना चाहिए कि this can be one last resort.
I have never needed to do that. Never needed and treated all of them completely. Let us give that message here, and it's okay. I mean, what you are saying as a bottom line, you know, as a sideline, it's okay. But let us give a message that please try to follow them, treat them.
Absolutely.
But Nisha, many times it happens that you are sure that this patient will never come to you again, and she is of 45 years of age with very big uterus. Then you may need to, you have to individualize sometime also. Yes. Although we need to stick to the guidelines, but many times we have to take decision on depending on your patient also.
Ma'am, what chemotherapy will you give and how will you follow that? Let's come to that.
We'll come to that later.
That is for the only single dose. That is only prophylactic single dose. If the patient is not coming for that, you have to counsel, you have to refer that tertiary care center, you have to refer to the oncologist.
But how many times you refer, and many a times, at least I have seen in my patients, आपने ovarian cancer operate करा, हिंदी में, English में, हर तरह से पिक के कीमो कैंसर हॉस्पिटल कीमोथेरेपी के लिए भेजा, वो they don't turn up. आप इतने frustrated हो जाते हैं. So I mean, let's be open. I know the very right message Nisha is giving, and that is the good message. Everyone should try to follow it. बस अपने दिमाग को little bit open रख के हमें circumstantially जो करना है accordingly for the benefit of the patient. Ultimately, we are all working.
Okay, thank you, Nisha, for your input. Now, Dr. Kanchan, are you there?
Yeah,
Dr. Kanchan.
Yeah, ma'am.
When to do hysterectomy in case of H-mole?
Ma'am, in case of H-mole, normally we don't advise hysterectomy follow-up, but in case we advise, in case the patient is more than near about 40 or more than 35 and have completed her family, and fertility preservation is not required, and there is intractable hemorrhage even after evacuation, and patient is high risk for post-molar GTN and non-compliance. But the one thing which is to be kept in mind, that hysterectomy does not reduce the metastasis, chances of metastasis. So that is to be counseled to the patient. Very well.
So even after hysterectomy,
yes,
counsel the patient. She needs follow-up. She needs follow-up.
Yeah, ma'am.
Because even after hysterectomy, patient has to be kept follow-up, as the hysterectomy does not completely eliminate the risk of post-molar GTN. So the follow-up is a must. But the hysterectomy is indicated in cases of the woman more than 40 years and family, she is not willing for the further family. And there is the intractable hemorrhage. Sometimes we do, patient is repeatedly bleeding, we do the hysterectomy. But after the hysterectomy, follow it with must.
Yeah.
Hello, Kanchan.
Ji ma'am.
Hello, Kanchan.
Ji ma'am.
Dr. Nani here.
Yes,
Oh,
sir.
namaste, ma'am.
When you do the
Namaste, madam.
hysterectomy, definitely the follow-up with chemotherapy is very necessary. Until unless you are sure that you're, sometimes there is a relapse in the vault of the vagina. So you have to be very careful, and the follow-up is required, even after hysterectomy.
Thank you, ma'am, for your input.
Thank you, Dr. Nani.
One thing, Kanchan, would you preserve the ovaries or will take out the ovaries as well?
They should be preserved.
Ovary
Ovaries
must
should be preserved.
Good. Even thecal uterine cyst is
Thecal uterine
present, that
cyst
should be-
also regress.
that should be
Very
added.
good.
They regress there, sir.
Ovaries never to be
Hysterectomy with
removed.
the
Yeah,
hysterectomy
they
with
regress on their own.
self-injecting.
Yeah.
Yeah.
Thank you, ma'am.
So thank you.
Over to
Thank you
Kiran.
all thank you all the panelists and the experts and our seniors for actually solving the various controversies and the challenges which we are facing. I'm happy that we are having a very nice discussion into this. Now, this is a second case which has actually come to our hospital. So I'll show you. It's a 28-year-old patient, P3+1, with complaint of on and off bleeding per vaginum since 2 months with very severe anemia because she was bleeding for a long time. Past history, on inquiry, she gave history of suction evacuation of a molar pregnancy 1 year back. She was followed by beta HCG at that time, which returned to normal within 3 weeks, and then she left the further follow-up. She did not get it done. Once it came normal, she became quiescent. She has undergone dilatation. Once again she started bleeding, so she undergone dilatation and curettage by a local practitioner. She was anemic, so she was also given 3 units of blood, but her symptoms did not improve, and which brought her to our side in the hospital. On examination, her abdomen was parabdominally, it was soft. Speculum examination, there was slight bleeding present, and on biomanual examination, uterus was bulky, bilateral, adnexa were enlarged and cystic. So, Dr. Priyanka, over to you. What would you like to do and how will you proceed for it?
Yeah, good evening, ma'am. Yeah, she's a case of molar pregnancy evacuation 1 year back, and she was followed out very well, and the beta HCG level came out to be normal at 6 weeks. But the follow-up does not get completed just at 6 weeks, ma'am. As has been told that you need to do beta HCGs every weekly till they come out to be normal, and then monthly or 3 monthly, whatever Urmila ma'am was talking about. So we do not have now we need to get a beta HCG done probably, ma'am, which I would like, because she has already undergone dilatation and curettage. We feel that her uterus is bulky. So a vaginal examination, ultrasound examination, X-ray examination, a beta HCG need to be done, ma'am, actually.
Yes, very right. And I mean, as you said itself, after the molar evacuation, initial follow-up was there, then the further patient was lost for follow-up, and she came with the bleeding. So post-molar GTN you are suspecting, is it?
Maybe, ma'am, it can be another pregnancy also. Though
It can be. It can be.
Ultrasound, specifically, ma'am, an ultrasound and a beta HCG will guide us to our further management. But as per the diagnosis, then ma'am, we can move further like all other investigations and prognostic scoring systems, ma'am, if we make a diagnosis of post-molar GTN now.
Okay. So when will you actually say it is a post-molar GTN or
ma'am, when
otherwise?
histopathology,
Yeah, so,
beta HCG is more than 1 lakh and I have a histopathology available with me, I think.
Priyanka, I think Dr. Mamta is not there. So Dr. Mamta has not joined. So I think you only take this case for question. When will you finally say that these are the features present, these investigations are present, and this is a case of actually post-molar GTN?
See, if the beta HCG level is more than the, we'll be going by the FIGO guidelines for diagnosing post-molar GTN. So, ma'am, there are 4 criteria which they are, but they don't fit into this case, ma'am. Should I talk about these criteria first?
No, you talk your own, whatever it is. When you have already said that HCG surveillance is the most important thing.
Yes,
right. So that is one thing.
Yes. So, ma'am, an ultrasound examination with showing RPOCs, whatsoever we have, if we have something on ultrasound, then ma'am, we can do a DNA and go for the diagnosis if we want a certain histologic diagnosis. But if beta HCG is more than 1 lakh, now we do not go for any histologic diagnosis and label it as post-molar GTN and treat it there. But the FIGO guidelines which we need to remember is that is once we are following a case of molar evacuation, then we call it post-molar GTN if beta HCG values across 4 measurements, that is 7, 14, example, this is an example, first value, 7, 14 and 21 day value, all of them are plateauing, or there is a rise in beta HCG, more than 10% for 3 values, not just for 1 value, like we have 1 which is higher, then again we need to follow up it for 3 values. And that is what I was wondering, madam said that she said that 56 days is a period when they say that beta HCG should come down to normal. But according to FIGO guidelines, HCG persistence after 6 months, then only we label it as post-molar GTN, not if it is around 2 months, 3 months or so, ma'am. That is it.
To label it as a GTA, post-molar GTN, you are right, after 6 months. But once, as what I think Urmila was saying, like 56 days or would you say 2 months, that means that this is the average time by which the HCG
comes down.
Yes, ma'am. So that is the thing. But if anything is going otherwise, like plateauing or rising, they are indicative and finally persisting after 6 months. That is the thing. Dr. Shelly, I think, yes.
Ma'am, one point I'd like to make here. So, the case that you presented, patient comes after 6 weeks normal हो गया था, उसके महीने 2 महीने बाद आपके पास आई हैं, तो कई बार क्या
एक साल बाद
it is about 1 year. Okay, all right. So this is after 1 year, but what I wanted to highlight was that many times whenever these patients come, then people will do 1 beta HCG, and then it is somewhat like, say, there is no pregnancy on the ultrasound, but then there is a tendency to not to wait. There, if she's not bleeding, you better wait, do it 3 weekly. So many times, even in my team also, members will say, it's okay, do to aa gaye hain, let us decide on that. Let us stick to it. If she's not bleeding, then you just measure those 3 and then take a decision. And so that your treatment, your FIGO scoring will be correct and your levels, what you have achieved, will be correct. So
Nisha, sorry to interrupt you. This patient has been bleeding off and on, and she has become bled so
anemic.
Much that she has become anemic. 3 bottles of blood has been transfused. She was
no, ma'am, that's all right. That's all right.
So we are talking in this case only.
We are just talking of this case. Huh?
Yeah, because you were discussing the guidelines for this thing. So what I was trying to say, when normally a patient comes, we try to follow like that. But when they come in between, after some follow-up and then there's a break and then they come. So I was just trying to highlight that you still stick to this.
Okay, got it. You wanted to, right. So the message you wanted to give it, even if they come in between and they I mean, this is the, I mean, you have to follow the same guidelines. So I agree with it. In this case also, actually what the tests were done, that will come later, but here it was a different situation. Okay, so Dr. Shelley, although
Yes,
they
ma'am.
have been discussed, but I would like you to highlight again, because they are very important. What are the risk factors for post-molar GTN?
Good evening to all the experts and all my co-panelists. As we have already discussed the risk factors, I'm just repeating. First and foremost is the SCG level. If it is more than 1 lakh milli international unit per ml, or if you have find the excessive uterine enlargement, like it was more than 24 weeks or 32 weeks at the time of evacuation. And then of course the thecal uterine cyst, which should be more than 6 centimeter or larger. And age is also very important. If the patient is in this age group more than 40 years, then she is definitely a high risk for molar GTN. So these patients should be counseled very effectively, as by Dr. Nisha Singh ma'am says, she has not lost even a single patient in her counseling. So we must counsel these patients like her only. So these are the risk factors in which we need a strict follow-up.
Strict follow-up and strict watch what they will, I mean, how they will behave, and accordingly take the judgment for these patients. Very rightly said. So in this case, the situation came out to be that her investigations at beta SCG turned out to be 2,25,000. Thyroid and coagulation profiles were normal. Ultrasound showed bulky uterus and increased vascularity, and a hypoechoic lesion of 7.5 into 5.7 centimeter into endometrial cavity, which could be anything. The next question is, how will you manage? Niharika has not also been able. Dr. Niharika, are you there?
No, ma'am, she has not joined.
She left
sent a
recently,
message.
yeah.
I think Dr. Shelley, can you take up this thing?
Yes,
How will you
yes.
manage the case? Yes.
As a patient is bleeding profusely, she has needed 3 blood transfusion in the past. So I would like to take this patient to OT and for the surgical management, because she was bleeding. So and then according to the
this patient was taken for exploratory laparotomy, and the interesting thing, or whatever unfortunate thing, was the uterus was bulky, 22 week size. There was a perforation on superior anterior aspect of uterine fundus and anterior cervix also. Total abdominal hysterectomy was done. 5 units of PCV, 5 units of FFP were given. Post-operatively, her beta SCG came to be 5,000 milli-international unit per ml. She was also kept on the low-risk chemotherapy, which I'm not going to discuss just now. This is the photograph of this section. You can see that lesion which was seen there, and the perforation also site, if I'm able to show you. The perforation site were there, and this was the lesion which in there could be seen here. So
maybe invasive mole also,
Kiran,
no? Or it was
it was
perforation?
more in favor of invasive mole, ma'am.
Yes, yes, yes.
It is the invasive mole, I think, probably. That's why it has penetrated.
Absolutely, madam. That is what. So
Ma'am,
how will you
ma'am,
now?
can I add something, Kiran, ma'am?
Yes, yes, of course.
Yeah, ma'am, this case was very rightly managed because she was bleeding. She needed a hysterectomy. But one thing which I want to highlight is, even if there is a persistent GTN, ma'am, histopathological diagnosis is not always necessary. So we should not actually keep on taking them for DNCs again and again. If beta HCG level is more than 1 lakh, and patient is asymptomatic, probably not bleeding, then we can directly keep her for chemotherapy, and hysterectomy is also not necessary in such cases. Ma'am, आप क्या कहते हैं इसमें?
Let's Saroj, आप कहोगे पहले?
In this case, because she was bleeding,
ये तो
so there was no
invasive mole ही है.
Otherwise, I would have definitely given 1 or 2 courses of chemotherapy, and then to decide regarding the beta SCG level, how much it has gone and how much is the lesion, because we also have to remember that those cases which are localized, like PSTT, or because those are the cases which are localized inside the uterus, and they are better managed surgically rather than chemotherapeutically. But it may be that before doing surgery, we may give 1 or 2 courses of chemotherapy and then do surgery if required. If that is bleeding, and if it is placental site trophoblastic tumor only, not metastasized anywhere, then of course we have to think of surgery.
Yes,
Otherwise,
surgery actually was taken in this case because she was bleeding
was
too much and there was a
Yes.
suspicion of perforation. So we were, but the way she was behaving, it was suspected that it is an invasive mode. So we took this case.
And also in the ultrasound, we have seen the hypervascular lesion.
Yeah.
Yeah,
So
but
even if the lesion is there, then also, ma'am, chemo acts. That is not a criteria.
Yeah, I think
but because she was bleeding profusely, that is a criteria.
So, ma'am, just a point on that. What Priyanka raised, the point is fine. I don't have any this thing with what was managed, the way she was managed, because you were the best judge at that time. She was bleeding and all that. But the point that she's trying to bring out, such cases, if because you have high beta HCG, you have on imaging a lesion that is there, which could most probably be invasive mode. They can be managed by chemotherapy also. As Dr. Saroj also said, that if she was not bleeding so heavily, or those indications were not there, she could have been taken up. So you do the scoring and you give low or high. I have a doubt here the kind of lesion. It was a big lesion, the size. So it will, the scoring that will tell whether she should go for a multi-agent or the single agent therapy with this kind of, because even the beta HCG is very high and the size of the lesion. So what Priyanka is saying is fine. These patients can be managed by chemotherapy also, if you do not have any pertinent indication to take up for surgery.
Yes, but in this case, actually, in this case, because she was bleeding and it was perforation, so that's why the management surgically was a must. Otherwise, what Priyanka said, I agree with her.
Yes, madam. Dr. Priyanka and Dr. Nisha both are saying rightly, and that is the one beauty of gestational trophoblastic disease. There they do respond to chemotherapy very beautifully. That's the part. In fact, that is what initially in the very beginning I said, we can almost achieve 100% cure. This is the good point about the.
But here the circumstances were different, actually.
Yes. So we have to see the different circumstances, how and in what circumstance, how we have to take the decision. So what will you do in this case is the follow-up, Dr. Amrita. Somehow the Dr. Amrita, you are
Yes, ma'am.
Coming to the follow-up. Saving us by
Every time I'm getting the follow.
Expert of follow-up.
Yes, it's weekly till 3 consecutive HCG levels are normal, and then they are followed monthly for a year.
Yeah, so little bit difference is this only, that otherwise in normal cases, if up to 6 months they are normal, then here it is 12 months, consecutive months, it has to be normal because it is an invasive mode. And of course, chemotherapy, she was kept on low dose chemotherapy, which we'll discuss in another case. Okay, so let's move ahead. One more case I'll take, and then Urmila will be taking another case. So this is a lady, 28 years old, P3+1 with previous 2 LSCS. Came with recurrent episodes of heavy bleeding per vagina for last 1.5 months, following history of abortifacient intake. Her suction evacuation was done 2 times in emergency as a case of suspected incomplete abortion, but she bled profusely, and for which tamponade was done. Patient was transfused 6 units of blood. On investigation, it was found that the ultrasound highly vascular lesion was seen in the lower uterus and cervix, but beta HCG levels were 447.33 milli-international unit. So considering this, she was kept on injection methotrexate, 4 doses were given. Repeat beta HCG still came to 589 milli-international unit, and then third value came 81.39. Patient still kept on complaint of off and on bleeding. MRI was done, and that reported a case of complete hydatidiform mole with myometrial invasion. So what is the probable diagnosis, Dr. Amrita?
Ma'am, it is gestational trophoblastic disease only at stage 2B, because the lesions are there in the cervix and vagina also.
Lesions are there on the cervix and vagina.
Yeah.
The highly vascular lesions, yes.
But ma'am, in this case, SCG level is not very high.
But
it is less
HCG
than
is not very high.
500. Yes, it is less than 500.
Yes,
And
because she has been given
it has not responded well to the methotrexate
Yes,
also.
she has not responded to
It has not
methotrexate
responded.
well.
So
But she has
more
already
likely-
been given methotrexate.
It is more likely a case of PSCT as far as I can.
That usually occurs in
The levels
elderly.
are absolutely normal, ma'am. It is not high.
So
the biopsy is which-
So, ma'am,
Suspected also.
Ma'am, I want to say something here.
Yes.
So, just show the previous slide. They're writing 4 doses of methotrexate.
Yes, ma'am.
Yes,
Which
that
means
is
it's
what
just a one cycle. Isn't it?
Hello?
Yes, yes,
yes.
Yeah,
One
it is
complete
once.
cycle.
It is
But
one
beta
cycle.
CG came down to 81.
only.
So if
Yes.
yeah, it is 4 doses and then repeat beta HCG. I don't know. 589 is after all 8 days, or it is 81 after all 8 days. So
No,
after
it-
one,
It is, but the second dose is after 1 injection and then third. And then fourth, I think whatever the records
so
are
actually,
available
ma'am,
was this.
Records not available.
So actually, when we do, we give one course is of will have 4 injection leucovorin and 4 injection methotrexate, isn't it? One
Yes,
cycle.
correct. I have not mentioned the leucovorin. Actually, the main thing.
Maybe, but there is no
Ma'am, what I'm
records
saying-
are not available.
Yeah,
He
so
says
what I'm
only
trying-
one cycle has been given.
Yeah, after one cycle, if we get 81, it's good.
Yes, ma'am.
That's
But
what-
patient kept on complaining of bleeding still.
No, Kiran, MRI after beta CG being 81 after 4 courses of methotrexate, how
madam.
can it say complete headed form mole with
मैडम ये रिपोर्ट में आया था
वो गलत होगी क्योंकि दूसरी चीज you can also think of even scar pregnancies
Yes,
because
that is
we
what
had
I'm
previous to
coming,
previous to LSCS.
कि why not
सोचो।
correct topic in this case? Yes, ma'am, bilkul.
This can be second thing could be that she had invasion into the scar area.
Yes.
And
So
because of
bilkul,
that she had been bleeding.
Madam, I agree. We kept all that.
क्योंकि MRI की
differential
रिपोर्ट से
diagnosis.
मैं agree नहीं कर रही हूँ. I don't agree with this ma'am.
Even we,
MRI report.
Yeah.
Madam, ये हम
I
लोगों
think
ने
report is wrong.
Something गलत है उसमें कहीं
हाँ,
पे.
कुछ
क्यों
तो
मिला?
है।
क्या नहीं लग रहा तुम्हें? मुझे नहीं लगा 81 जिसका बीटा सीजी आ गया था.
हाँ, exactly.
दे दिए आपने और उसको अगर still bleeding है तो दे दिए. Some invasion into scar area. She is case of previous to LSCS. तो उसका नीचे किससे
that was the controversial issue क्योंकि MRI हम लोगों ने मतलब whatever we could do ये रिपोर्ट में आया था. We got it checked from other person also जो हमारे डिपार्टमेंट में है. She came with the MRI report. तो हमने अपने यहाँ पे हिस्टोपैथोलॉजी तो अभी तक आई नहीं वो बात. Let's see.
ये चार्ट मिथोट्रेक्सेट के बाद है.
हाँ ये मिथोट्रेक्सेट के बाद है.
मैम एक साइकिल.
मिथोट्रेक्सेट चार्ट के बाद
आगे चलते हैं.
मैम मिथोट्रेक्सेट दिया क्यों पहले?
Because उसका जो ये she has come with all this ना जो हमारे पास ये MRI
Okay,
की
okay.
वगैरह सब लेके आई थी.
ये सब करवा के आई थी.
चलो
तो
हाँ
जब-
ठीक है चलो
जब
आगे
हमने
चलो.
MRI उसका रीड कराया दोबारा तो उन्होंने भी मतलब सपोर्ट किया. हाँ
मैम
ऐसे ही लग रहा
एक्चुअली
है.
मुझे ऐसा लग रहा है उन्हें भी स्कार एक टॉपिक लग रहा होगा तो उन्होंने मीथोट्रेक्सेट इसीलिए दे दिया होगा कि भाई इवैक्यूएशन एबॉर्शन के बाद में इवैक्यूएट नहीं कर पा रहे तो उन्होंने मीथो लगा दिया मैम.
What-
आगे
जब
Trial and error.
MRI की रिपोर्ट को देख के जब रीड करा गया तो फिर प्रोबेबल डायग्नोसिस सोची गई. एंड देयर वी थॉट अभी हमारे पास भी इसका प्रूफ नहीं है. वी थॉट कि मे बी इट इज अ इंटरमीडिएट ट्रोफोब्लास्टिक ट्यूमर कि बीटा एचसीजी लेवल्स आर नॉट हाई बट अदरवाइज द पिक्चर इज ऑफ दैट ब्लीडिंग.
किरण निहारिका नहीं आ पाएगी. किरण
इंटरमीडिएट ट्रोफोब्लास्टिक मैम थोड़ा हायर एज ग्रुप पे होता है. ये पेशेंट काफी यंग है.
नहीं ये तो है बट ऐसा कोई प्रेजेंटेशन के लिए like otherwise the explanation let us see one explanation which has come scar pregnancy ka.
Yes ma'am.
Ma'am very true.
Kiran, did you get the message that Niharika will not come?
Okay madam, we'll take what madam जो भी लोग हैं वो लोग questions ले लेंगे.
ठीक है.
हाँ,
उसका
कोई बात
मेरे
नहीं.
फोन पे भी मैसेज आया दोबारा से तो मैंने कहा बता.
ठीक है जी मैडम, thank you.
किरण मैम
Okay जी.
Kiranji, discuss about.
Ma'am, ये intermediate.
Actually, Priyanka, what we do, अभी आपके, I understand, Priyanka, Dr. Nisha, everyone, the patient has come with this situation. Whatever we have just suspected, let
Ma'am,
us
we are
now.
agreeing with your diagnosis. मैं तो यही कहना चाह रही हूँ कि एक पेशेंट हमारे पास भी ऐसे ही प्रेजेंट की थी, बट तब उसको PSTT बोलते थे, अभी इंटरमीडिएट. तो this diagnosis is, मतलब this stands and fits into the case, ma'am. We can also make a diagnosis.
DD can be the scar pregnancy also.
As well, right.
But actually,
Should be
this
kept
is
in mind.
Dr.
Ketan, you
picture of
want to
PSTD.
discuss? You want to discuss that?
आगे चलो, आगे चलो.
हाँ, discuss
Okay.
करिए.
हाँ, तो let us see what are the. So we have to discuss. Priyanka, आप ही बताएंगे what are the characteristic features of ITT which differentiate it from other forms of GTS.
Yeah, ma'am, we have already discussed one thing, that beta HCG levels in ITT is not as high as it is in the other GTNs, because they tend to produce less HCG. But yeah, it has been found that placental lactogen, HPL in LDH and HPL are raised in a fewer of them cases. These diseases are just confined to the uterus for longer duration. But ma'am, ultimately, because they do not, because they produce less beta HCG, they do not respond to chemotherapy also. So these are slow growing tumors that they can metastasize later on also, matlab months and years after that. So that is why we need to be very careful about these. And they comprise two types of tumors. Number one is PSTT, that is placental site trophoblastic tumor. And second is ETT, that is epithelioid trophoblastic tumor.
So though very rightly, Priyanka, you have said that they are only 1%, very rare. But sometimes you do come across with such type of confusing picture. And even as somebody was asking histopathology, I tell you, कि मतलब just before this panel when I was making, I tried to find out pathologists भी इतना pains नहीं लेते हैं, and they just don't give this much of clear cut picture every time कि ये PSTT वगैरह की picture epithelioid की मिलती ही नहीं है. वो
Ma'am, when I was in department in Kirti Dubey ma'am's unit, ma'am, we had one case. हमने उसका फिर biopsy, it is very difficult to get biopsies from these tumors also, क्योंकि endometrial cavity में तो बहुत ज़्यादा होता नहीं, but biopsy turned out to be PSTT, ma'am.
That's good. That's good. But actually, let us keep all the differential diagnosis और अभी हम इसको discuss कर रहे हैं. तो निहारिका नहीं है. Some who would like to, Shelly, आप करेंगे discuss या कोई भी ले ले. What is the role of IHC in extravillous type of GTN?
Basically, the molar pregnancies and choriocarcinoma, they are easily diagnosed on the histopathological examination. But as you have said, we do not have enough technology to diagnose these type of PSTT, ETT. So here comes the role of this IHC, immunohistochemistry. So basically, there are two types of these P63 inhibin, which are important differentiating these two forms, as both are extravillous. So PSTT, the P63 is negative, inhibin is positive, while it is reverse in case of ETT, in which the P63 is positive, but inhibin can be positive or negative. But we do not have the facility for ISC, as in Kanpur we have not.
Shelly, we don't have a facility in Kanpur, but I had one patient, and Dr. Asha Agrawal, you know her very well. So उन्होंने IHC advice किया था. She told me the place also कहाँ बेचना है. She was a doctor's wife.
It is very costly also, ma'am. It costs around more than 5,000.
She was a doctor's wife. So we sent IHC also. So मतलब like in India it is available.
In India it is available. In metros it is available. Yes, ma'am.
We don't need to do just like, but आपको थोड़ा सा एक IHC का idea होना चाहिए कि this is possible. Otherwise जैसे प्रियंका ने I think point out किया कि histopathology will not always give you the correct, मतलब differentiate between the PSTT or ETT, and we don't.
ये होने लगा है कि सब कई
सब भेज देते हैं मैम, स्लाइड्स वो बाहर भेज देते हैं.
हाँ वही, मतलब हम लोग स्लाइड भेज देते हैं बॉम्बे वगैरह जाके, दिल्ली वगैरह, वहाँ हो जाते हैं.
हम लोग भी करवाते हैं.
KGMU में रूटीन
में होता है, इम्यूनोहिस्टोकेमिस्ट्री
में होते हैं, और वो लोग चार्ज करते हैं जिस टाइप का IHC लगाना है. फॉर ईच टाइप दे चार्ज 500 और 1000 ऐसे करके. तो कभी स्लाइड्स वो करानी हो तो लखनऊ विल बी नियरर फॉर यू मे बी. एंड सेकंड पॉइंट वाज दैट अबाउट द हिस्टोपैथोलॉजी, mostly these diagnoses will be established when they're not responding, the levels are not falling, and you're seeing that, and you go do a hysterectomy, and after that maybe on that tissue they will be able to make a diagnosis, but otherwise it is difficult that way from the biopsy tissue, from a small tissue.
Very right, very right, very right. So what will be the treatment approach?
Yes, ma'am, as we have discussed, it is not a very chemosensitive type of tumor. These ITTs are not very chemosensitive. So the surgery is the mainstay of treatment. So, and these tumors have a tendency to invade the lymph nodes. They spread to the lymph nodes. So hysterectomy along with the pelvic lymph node biopsy is the mainstay of treatment. And then, of course, these patients need a thorough follow-up. And these patients can be further categorized in two categories, that is the low risk and high risk. According to the factors that if the interval between the index pregnancy and the event is less than 2 years, or we have seen only the superficial invasion on the specimen, there's no necrosis present, or the mitotic count it is less than 5 to 10 per high power field, then these patients are kept on the SCG surveillance. And then if during this surveillance time they show the signs of recurrence or they have some progression, then we go for the systemic therapy. Other category is when the interval, मैम जो हमारी अभी नॉन मेटास्टैटिक कैटेगरी है जिसमें केवल हमें लीजन वहीं पे था, यूट्रस में ही था. इफ द इंडेक्स प्रेगनेंसी एंड द इवेंट का इंटरवल मोर देन 2 years है, या डीप इन्वेजन है, या नेक्रोसिस प्रेजेंट है, या माइटोटिक काउंट जो आपका उसमें आया है उसमें मोर देन 5 to 10 पर हाइपर फील्ड है, then these patients should be considered for the systemic chemotherapy and also for the SCG surveillance. But if it is a metastatic type, then you have to do the hysterectomy along with the excision of whole the metastatic disease, which is possible. And then these patients need a multiple chemotherapy in the form of platinum or etoposide based regimes. And then they have to be monitored.
Okay. So very rightly, you have said ki, and everybody has agreed and understood this, ki these are not very much responding to chemotherapy initially. So first line of treatment is surgery. If not metastatic, only hysterectomy with lymph node. If it is there, then with metastatic lesion is also removed completely, and then follow up and strict monitoring. So in this case, total abdominal hysterectomy and bilateral pelvic lymphadenectomy has been done. Peroperatively, uterus was bulky, mass perforating again through the previous scar. Now, histopathology will later on only tell us what. So bladder was adhered to the scar. There was the right ovarian cyst linked to be theca lutein cyst. So that again, we think in this way. Left tube and ovary was normal. Lower uterus and cervical region were hypervascular and tissue was very friable. On cut section, myometrium was hypertrophied. Invasive mass of 5 into 5 centimeter was filling in the lower part of the lesion. So this was the picture. And we don't have the, actually...
Dr. Nisha, this was for the discussion of ITT. Actually, reports are not available.
I know that. I understood that.
The report is not available. Actually, it is not that it has been done, Abhi. It has been done, but patient has been in the COVID time. She has not come back to us. So we don't know कि उसने histopathology कराई, नहीं कराई, report क्या आई, total.
Because sometimes we do the hysterectomy in the emergency, patient comes with the bleeding and the low condition and she required blood transfusion. The histopathology is later on, then we do the chemotherapy and all those things.
This was
ma'am.
Yeah.
Ma'am, actually, just for discussion point of view, as ma'am said that this could be scar ectopic also.
Yes.
So what was done, ma'am, because had it been a scar ectopic, तो वो तो laparoscopy ही laparoscopically excision and उसी से manage हो जाती. So ma'am, आप क्या advise करते हो in such cases?
It is not possible
what other
laparoscopically.
investigation हमें help कर सकती है?
किस चीज में किस चीज की advice?
Otherwise the patient has to go for hysterectomy and lymphadenectomy and everything, na?
Yeah. So like, see, that depends only on when you have limited, investigation and the patient's condition, you have to depend on your clinical thinking. What you feel you have to save the patient ultimately. So when you're for the patient benefit, whatever lymphadenectomy has been done, that is okay. But that because at the time of the operation, thecal lutein cyst was there, and the uterus was removed. The invasive mass was there. It did not look to be the scar pregnancy, but maybe we can't say. Without histopathology, kuch commit
Ma'am,
karna.
is there any role of frozen section in all these cases, ma'am?
Yeah, but we
just
don't
for
have.
the panelists, just for an idea, ma'am, we have it in merit also now.
Acha, we don't have a.
So we can, ma'am,
of course you can do.
Just aise ki we can, if we are doubtful about the diagnosis, then on table frozen section might actually save her from a hysterectomy. That is all. That is the crux of the.
I know. Very good point. I mean, this is for discussion only. So all the new points are coming up. So they should be increase our visual field.
Yeah.
Okay. So I think Urmila, you can take up this case.
Come to the next case. So
yeah, next case I put.
So there was the discussion on ITT without histopathology report. That was for only discussion.
हाँ, but Urmila, this entity, these PSTT and ITT, जब हम लोग resident थे तो नहीं discuss होता था.
इसीलिए ये करा गया कि entity लोग जाने कि ये भी होता है.
So it has to be discussed. It has to be thought, kept into the mind also.
Yes. Meera ma'am has joined. Namaskar, Meera ma'am.
Namaste, ma'am. Good evening, ma'am. We are missing you,
ma'am. आप mute है, Meera ma'am.
I agree. Frozen section keys may help could have be a better option.
Yeah, madam, अगर हो facility कानपुर में कराइए ना, आप भी करा सकते हैं.
अच्छा, पर
कानपुर में नहीं है frozen section.
अच्छा, frozen section तो आजकल बहुत जगह हो गया है.
मेरठ में तो 3-4 जगह पर है. हम भी बड़े सरप्राइज्ड है कि कानपुर में
दिल्ली के पास वाले हैं ना प्रियंका जी, दिल्ली के पास.
आप हमारे पास
ये बात नहीं.
नहीं है मैडम, हम लोग बहुत लिमिटेड उसमें ही काम करते हैं. मोर ऑफ अपने ही क्लिनिकल पिक्चर और व्हाटएवर रिसोर्सेज वी हैव उस पे. और अभी तो कोविड में तो सारे जो कुछ हो भी रहा था, लाइक
मेडिकल कॉलेज शुड स्टार्ट आपके यहाँ.
Yes, because in these cases frozen section is very good. I think it's a great help.
वेरी गुड मैडम, सही बात मैडम. यही तो है ना, अगर हमारे पास पूरी फैसिलिटीज होती है तो वी कैन गिव बेटर.
आपको वहीं का वहीं पता चल जाए बस. हाँ,
बिल्कुल मैडम. मीरा जी वेलकम. आपको अभी ये केस के बाद फिर आपकी ब्लेसिंग्स चाहिए होंगी हमें.
तो मैं पूरा सुन रही हूँ. आई एम लिसनिंग एवरीथिंग एंड आई एम एंजॉयिंग इट. और
जी मैडम,
बहुत अच्छा है कि ऐसा होता तो क्या होता और वैसा होता तो क्या होता है.
जी मैडम.
नमस्कार. जो हुआ वही होता.
और उषा जी, वैसे बाय द वे आई मस्ट ऐड एज ए क्लिनिशियन कि कभी देर आर वेरी मेनी गाइडलाइंस और SOPs along with us, but when we are operating,
but you cannot follow them always.
When we are operating, you see, we have to take decisions against the current, and we have to save the patient. So there are guidelines, there are SOPs. हम अपने DNB और MS के students को भी यही बताते हैं कि every patient is a different patient, and sometimes and land up into a problem which you have never seen, and you have to just do what you don't want to do to save the patient. That is what I wanted to tell you.
Yeah. And which may not be mentioned in the books also.
Which may not be mentioned in the books.
जी मैडम.
I agree. लेकिन किरण, हम लोगों को सैंक्शन हो गया है पैथोलॉजी डिपार्टमेंट में, और कोविड की वजह से हमारी बहुत सी चीजें पाइपलाइन में हैं.
यस, वही मैंने कहा मैडम, कोविड की वजह से बहुत सी चीजें रुक गई हैं.
ऑलरेडी देयर, मेरे सिग्नेचर भी उसमें हो चुके हैं, लेकिन कोविड की वजह से बहुत सी चीजें स्टैंड स्टिल हैं. दे आर स्टिल इन द पाइपलाइन.
जी मैडम. जी, लेट्स होप सो टू डू बेटर. उर्मिला, आप
So, and case number 4, Mrs. X, 31-year-old, para 0+1, married 1.5 years back, came to us in August 2021 during COVID period with complaint of irregular bleeding PV since May 2021, following DNC done for the missed abortion in the May. She also had the history of repeated twice DNC for the abnormal uterine bleeding And tissue, at that time, the tissue was not sent for histopathological examination. There's some done at the periphery. So she come to us on examination, general condition was good. On per-abdominal, abdomen was soft, there was no mass felt. Per-speculum, slight bleeding from inside cervical os was present. Uterus, cervix was forward, uterus retroverted, bulky, firm, mobile. Fornices was clear. Dr. Meenakshi, are you there? Dr. Meenakshi?
She is there.
She's not. Anybody can take this case. How to proceed in this case? Hello?
Yeah. Ma'am, of course, the patient has to, she's has undergone DNCs 3 times and still she is bleeding. Histopathology is not available. So she needs a complete general examination, a clinical proper examination, which has already been done. And everything seems to be normal. Her hemoglobin, etc. is also normal, but her serum beta HCG is high. So she can be a case of a hereditary form mole, or her ultrasound is needed. And on ultrasound here, there is a question mark for the arteriovenous malformation. So such cases, I mean, she definitely needs a follow-up.
No, she's bleeding. Her beta HCG is high. And the ultrasound is showing that the multiple grossly tortuous high flow vascular channels, posterior and anterior wall. Means there's the
vascularity is there.
So would you like to do repeat DNC?
No, ma'am. Definitely not. No DNC needed. But we can take her up for further investigation. Pelvic.
So what do you suspect? What she is bleeding?
Ma'am, she can be a case of
persistent GTN.
Yes, ma'am. Persistent.
Ma'am, she's a case of GTN now. So we need to do ma'am, because her beta HCG level is high. She has been bleeding multiple DNCs. Although histopathology has not been there, but again, this is maybe after abortion, maybe after H-mole. Now she is a case of GTN. So ma'am,
Yes,
we
ma'am.
now need to take her for chemotherapy, and her ultrasound also shows an AV malformation.
But
we need
excuse
to,
me,
ma'am, score
excuse me,
now.
Dr. Priyanka.
Yeah.
I think she needs if we are suspecting persistent GTN, she needs further investigation for metastasis, etc. Also.
We need to score her as
a chest X-ray is very much needed.
So next,
very true.
Coming to the next question, Kiranji, next slide.
Yeah.
I think this Kanchan, you are not there.
Yeah.
Okay.
Yeah, I'm here, ma'am. I'm here. As we have already discussed, the findings most probably goes in favor of GTN, gestational trophoblastic neoplasia, and follow.
So about 50% of GTN follows the molar pregnancy. Rest can occur after abortion, ectopic pregnancy, and term pregnancy.
Yes, ma'am.
Uterine
25%.
bleeding after any pregnancy. Remember, if there is the abnormal uterine bleeding after any pregnancy, you always investigate for the HCG.
Mamta is not there. Kanchan, you can take this. What to do?
What to do now?
For this, ma'am, first of all, we have to grade in low risk or high risk according to WHO modified. First of all, as basics, we have to do the physical examination, CBC differential diagnosis, platelet coagulation profile, radiological investigation, chest X-ray, of course, for the distant metastasis, pelvic ultrasound is to be done, cystic ovaries are to be seen. And for metastatic workup, we have to see the chest X-ray, brain MRI in case there are any features of the brain metastasis or a confusional state. And in case pulmonary metastasis is suspected, we can advise the CT also, pulmonary CT also. And this is the workup. After that, we can even grade the according to FIGO classification, FIGO staging, that says
Dr. Meenakshi,
Dr. Kanchan, we are suspected that she is a case of GTN. So baseline investigation done. Always see for the secondaries X-ray chest and the other investigation. And then according to that, by the ultrasound, by the X-ray chest, staging of the disease. So what is the, Dr. Meenakshi is not there. Dr. Meenakshi? Dr. Priyanka?
Yes, ma'am. Ma'am,
what is the
when we talk
for
of
choriocarcinoma?
Yes, ma'am, when we have GTN, ma'am, the message which should be given to all the audiences is that we need to actually prognosticate it according to WHO and grade it and stage it according to FIGO. So FIGO staging is very, very simple. We have 4 stages, 1, 2, 3, 4. One is when the tumor is confined to the uterine corpus only, that is uterus. Stage 2, outside the uterus, but limited only to the genital structures. Stage 3, when you have pulmonary metastasis only. That means because metastasis to the lungs is the most common metastasis. So if there is pulmonary metastasis, we grade it as stage 3 only. And stage 4 is when metastasis occurs to other sites like vagina. Even vagina is taken into stage 4 metastasis. Vagina, liver, or any other site. So that is how we stage.
But vagina is in genital tract, no?
Genital, they take there.
That is the genital tract.
No, stage 4 is the brain and liver. Distant metastasis, but the lung is taken in the second stage.
Third, ma'am.
Third stage.
Lung is taken as the third stage.
Stage 3.
And, or vagina is in the second stage.
Second stage.
Okay. So what is the WHO prognostic scoring for choriocarcinoma?
Ma'am, there are
May I
nine
take this?
parameters.
Yes, sure.
And in these 9 parameters, we do the scoring from 0 to 4. And then according to score, we give less than 7, it is low risk, 7 to 12 is intermediate, and more than 12 is a high risk. So these parameters are age, if it is less than 40, 0, more than 41. If the antecedent pregnancy, which was the index pregnancy, it was a hereditary form mole, then 0. It was abortion, then 1. If it was a term pregnancy, it was score 2. Then the interval between the index pregnancy and this start of chemotherapy in months, less than 4 is 0, more 4 to 6 months is 1, 7 to 12 months is 2, and more than 1 year it is taken as a 4. Then SCG level as a time of diagnosis, which was the first reading of SCG. If it is less than 1000, it is 0. 1000 to 10,000, it is 1. Then 10,000 to 1 lakh, it is 2. And then more than 1 lakh, it is taken as a 4. Then largest tumor including the uterine in size. If it is less than 3 centimeter, 0. 3 to 5, 1. More than 5 centimeter, taken as a 2. The number of metastasis, 1 to 3 in the scoring 1. Then 4 to 8, 2. And then more than 8, taken as a 8. Then prior chemotherapy, she has received 1 drug, then it is 2. If more than 2 drugs were received, then it is 4. Then site of metastasis, if it is in spleen and kidney, it is taken as a 1. If the GI tract is involved, it is 2. And then if brain and liver, as it's told, then it is 4. And then accordingly, we do the scoring. Less than 7 is low risk, 7 to 12 intermediate, and more than 12 is high risk.
Less than 6 is low risk. 6. No, and we take 8 only. Yes, ma'am.
0 to 6 is low.
And
here,
lungs, here lungs is missing. For lungs, if the site of metastasis is lungs, it is 0.
Yeah, that is 0. Lung is 0. So if it is less than 7, it is low risk. And if it is 7 or more than 7, it is high risk. Next slide. So this patient was came as a low risk case after the scoring, stage 1 and low risk case. Kiranji, next slide.
Yes. Oh. Yeah.
Is the biopsy necessary to confirm the diagnosis of choriocarcinoma, Dr. Amrita?
No, ma'am.
No,
it is not necessary.
It is not.
We can do it.
If visible lesion are seen in the lower genital tract, do not do biopsy.
Yes,
But tempting hota hai, bluish nodule is present in the vagina and excise this. This is very
but it can bleed. It will bleed too much.
Yes, very
yes,
right. Very right.
Risky.
Risky. Dr. Pragati?
Yes, ma'am.
What are the typical pulmonary findings in case of choriocarcinoma?
In cases of choriocarcinoma, there may be in X-ray chest, there may be cannonball shadows or snowstorm pattern, and in MRI, there may be discrete rounded densities, and we may find pleural effusion also. And there are embolic pattern. There are pulmonary arteries. There is embolism of that arteries. Therefore, there may be.
So very well said. These are the picture of the pulmonary metastasis in cases of choriocarcinoma. Next question. So the Mrs. X came as a GTN stage 1, score less than 5. So what is the treatment for Mrs. X? Dr. Priyanka.
Yes, ma'am. Ma'am, now because she's a low risk case, so the treatment would be single agent chemotherapy, ma'am, either methotrexate or actinomycin D. We gynecologists are actually more used to giving methotrexate. So methotrexate, which was already, it has been described, the 8-day regime. That means 1357, 50 milligram methotrexate and 2468 folinic acid rescue. And this is this regime now, because earlier for persistent GTN days, the entire course has to be repeated after every 14 days, and we need to follow it with beta HCG. So after HCG level, that is after every 2 weeks, ma'am.
So this table is showing the various single dose regime, but the NCCN guidelines recommend initial multi-day methotrexate only 5 days, or methotrexate with the folinic acid regime. Actinomycin D regime for the patient with the contraindication for the methotrexate therapy. So the Mrs. X received 7 cycles of methotrexate and folinic acid regime. Now a 7th course has been received. Now the beta HCG 1.2. What is the recommendation for the consolidation chemotherapy? Dr. Niharika is not there. Anybody can take this question.
The levels have come down. So we can keep follow up, and we give 1 dose extra after the remission.
FIGO and NCCN recommend 2 to 3 cycles of consolidation chemotherapy after SCG normalization. Okay. When the beta HCG had a beta HCG was 1.2, after that you have to give 2 or 3 cycles of single agent chemotherapy. That is the consolidation therapy. So
and follow-up is for 1 year, ma'am, as already discussed in the slide. The beta HCG follow-up in these cases is for 1 year as compared to 6 months in previous.
Yes. What contraception you will advise? Patient want to conceive. Patient want to conceive. क्या हमें pregnancy करना है? अब patient she is menstruating regularly. Would you like to advise contraception?
Yes, for
contraception is preferred for a year.
Yes,
even if she
for 1 year.
conceives.
For 1 year.
Contraception for a year, but even if she conceives in between, there's no problem. We can follow her up properly, and if the baby,
but the beta HCG follow-up would not be able to done.
No beta HCG, no ultrasound.
So you have to give the contraception at least for the 1 year.
For a year.
And low dose oral contraceptive during chemotherapy is not contraindicated. It is preferable give the OCPs during this follow-up.
Yes.
Yes. So what is the treatment protocol for the low risk GTN? किरण जी next slide कर दीजिए.
Already done, ma'am.
Already
single agent का हो गया सब. Yes.
How many questions more, Kiran?
Last,
ma'am.
I think Kiran जी आप अपना वो वाला ले लीजिए क्वेश्चन SCG and phantom.
As you wish. अगर जैसा कहीं नहीं तो अगर इसी केस को
नहीं वो कोई बात नहीं है. You should complete it. मैं वैसे ही पूछ रही थी.
Okay, मैडम ये इस केस में तो 1 ही 2 क्वेश्चन है शायद. शैली आप क्विकली ले लीजिए हाई रिस्क को.
Yes, ma'am. High risk in this. We start the multi-drug chemotherapy. Basically, the IMACO regime, that is etoposide, methotrexate, actinomycin D, cyclophosphamide, and
principle बता दीजिए.
Yes, ma'am.
ठीक.
So, as ma'am has said, if it is a low risk, if it is the intermediate risk में normal SCG आ गया, उसके बाद भी 2 से 3 cycle we have to give as a consolidation therapy.
Consolidation.
And then 1 year follow-up is important. But if after the initial good response, patient is having a plateau or she is having a relapse of disease, then we have to switch to EMA-EF therapy, in which this cyclophosphamide and oncovin is replaced by the cisplatin drug. On day 8, it will be replaced by this. And if she is having poor response to our treatment, after initial therapy, there is no decline in the SCG, then we have to consider as a chemo-resistant case, and then we have to resort to the surgical treatment, or we should add the etoposide along with the platinum-based regimes.
So there is the condition that ultra high risk cases. The ultra high risk cases are when the score is more than 12, and for that the treatment protocol is different. किरण जी नेक्स्ट कर दीजिए, क्वेश्चन ही पूछते बता देते हैं इनको खाली, ठीक है? Okay. In the ultra high risk cases, we should consider the induction low dose AP regime. Why? If you are giving the high dose regime initially, the secondaries will collapse. There may the risk of hemorrhage. There is the metabolic disorders are there. Sometimes there's the death is there. So always start with the low dose of etoposide and the cisplatinum for 1 to 3 cycle, and thereafter you come to the standard imaco regime. This is the message for the ultra high risk cases.
Ultra high risk cases, as you have written, more than 12 prognostic scores. Tab usko ultra high risk mani. Yes. So that is the message. Okay. So the next case, we'll quickly do it. It is actually not the original case. Not a case. It is just to give you certain those terms जो अब आ गए हैं अपनी guidelines में और उसमें. So everyone should be familiar with this. So we have just made it. It is a 35 years age follow-up case of low-risk GTN, received chemotherapy for 1 year back, after which she has attained remission. And now she has come with the beta SCG report of 293. Her lower ultrasound, lower abdomen was done, no abnormal findings. Her beta SCG was repeated weekly. It came out to be 291, then 286, then 281. So what do you think, Dr. Pragati?
Yes,
what can it be?
Quiescent gestational trophoblastic disease.
So what is that? Can you explain a little bit?
Yes, in this there are only the beta SCG is raised in a lower level, and there are no clinical findings or there is nothing in. It is an inactive form. Actually, it is an inactive form of GTD.
So what do you want to, what has to be done? Inactive, very rightly, because the idea was to tell it कि कोई एकदम से nothing, you don't have to jump for the treatment and chemotherapy. As I mean, you have to wait and watch and understand. As ultrasound was showing no disease, no complaint is there, only beta SCG level is there. So it seems to be a case of quiescent. They do not progress to invasive disece. And
yes, only follow will be required.
Sorry?
Only follow will be required.
Only follow-up will be required.
Then
Very,
we can
very.
do hyperglycosylated SCG.
Okay, so let's see. What is hyperglycosylated? Hyperglycosylated.
Larger size of HCG, which is secreted by the cytotrophoblastic cells. Okay. And it indicates that the cytotrophoblast is multiplying and there is a high risk of choriocarcinoma or some other malignancy.
So in this case, Dr. Shelley, if we, as Dr. Pragati has said, immediate nothing has to be done, neither the chemo nor the major, you have to do the follow-up. Long-term monitoring is required. But is there any time when you would like to do some treatment?
Yes, ma'am. Either the patient becomes symptomatic, or as she has told, we should do the SCG-H, that is the hyperglycosylated SCG, which is secreted by the cytotrophoblast, and it is specifically for the invasion. Otherwise, rest of the SCG is secreted by syncytial trophoblast, and which is not that much prone for the invasion.
Yeah, so we basic idea was to make everybody familiar with this, that HCG-H is also not there. And Priyanka,
yes, ma'am.
Will you tell us more about it, SCG-H, or
okay?
What is the?
Ma'am, already Dr. Shelley has told that it is reduced.
What is the relevance? Anything, like you have very rightly, you have said it, but the only thing which I wanted extra to say, it's a 100% sensitive marker for distinguishing the active GTN and choreo, active GTN or choreo from the quiescent. That is the main thing. Proportion of SCG-H to total HCG. That can be done. Okay, so anything, what do you think about the phantom antibodies for false positive beta SCG? What do you understand by Mamta is not there? Anybody would like to take? Madam, this is the last slide question.
Okay. False positive beta SCG is when patient is having a report of beta SCG positive, but it is not, the pregnancy is not there. So we call it as a phantom SCG. It has many causes. Like it can be due to the raised level of FSH, LH in the pituitary. Sometimes pituitary may secrete the SCG, which is not related to the pregnancy. And sometimes some individuals have some heterophil antibodies in their serum, which reacts with the antigen and gives us a false positive value of SCG. So it can be occur in 1% of perimenopausal women and in 7% of postmenopausal women. So this is importance is this key. We should know about this entity and we should diagnose whether it is a phantom antibodies which is causing the beta SCG false positive. So the unnecessary treatment, unnecessary concern and stress can be removed.
Yeah, that's very important because perimenopausal age group or postmenopausal may positive aaye, and obviously everybody will get so scared ki choreo ka hai, but that we have to understand it is phantom HCG and nothing has to be done. Follow-up can be of course done. So no treatment is required. That's
and basically we have to do, in these cases, we have to do a serum antibody, serum SCG quantitative along with the urine SCG.
Yes.
If the serum is more than 50, but we are not having urinary SCG, then it is more in favor of this heterophilic antibodies positive SCG.
If the serum SCG is more than 50 and urine pregnancy test is negative, you think about that, this is the phantom.
Yeah, that's what Dr. Shelley, very correct, very correct. So I think with this,
very nice. Very nice.
एक point,
yes,
just add करना था जो last वाला case था आपका. Somehow it looked so familiar to me. Even the HCG values I felt were very familiar to me. I don't know why. Anyways, उसमें 2 points थे मैं raise करना चाहती हूँ. One is that AV malformation. So whenever this kind of report comes, now everybody jumps to conclusions. So we have to be very cautious. Case was managed well. They did not go for, otherwise people start talking iska embolization kara lo, ye kara lo karke. So ek wo bahut important point hai that when we get this kind of reports, we should be careful. Then second is usko beta SCG fall hone mein jabki 2000 se shuru hua tha and it took 7 cycles. So that is another point of learning. Usually 6 cycles tak mein low risk quality disease respond kar jate hain. But once in a while you get some patients in whom you have to give little more. So you have to maintain your patience. So 6 to 8 cycles mein respond karte hain. अगर फॉलिंग ट्रेंड अच्छे से दिख रहा है बट नेगेटिव नहीं हुआ है एंड 2 digit 1 digit वाले में है, so then you can continue. Otherwise we switch over to multi-agent chemotherapy that we know that whenever we are not seeing the desired response in the change in the beta HCG. That point anyways we have discussed before. So these were 2 important things I felt we should just talk about it.
Very right, very right. So, I mean, this is the end, but Dr. Nisha has given her important points. Dr. Saroj has also given. Dr. Saroj, would you like to comment anything more? Any key message? I think she is not there. Only one thing I would like to give one sentence only. In a case post-delivery, post-abortion, Molar ke baad to aayega to we all are cautious, but post-ectopic, if even after management, patient continues to have off and on bleeding, just keep in mind. And for the gestational GTN, beta SCG should be done. So that is the one simple key message. I wanted to give, क्योंकि जब आ जाएगा पॉजिटिव तो फिर उसकी वैल्यू के अकॉर्डिंगली
रिपीटेड डीएनसी करते जाएंगे, रिपीटेड डीएनसी
रिपीट डीएनसी 2 के बाद बिल्कुल नहीं होना चाहिए, अगर फर्स्ट में नहीं है सेकंड में।
लेकिन अपने पास जब आते हैं तो 2-3 बार करा के आते हैं।
आई नो।
हाँ, तो इसलिए यही बात है ना, इसलिए कि अगर ऐसा आ रहा है बार बार तो सबसे पहले बीटा एससीजी करा ले and then decide according to the unit क्या हो रहा है। मतलब this thing should be kept in mind। जो मिस हो जाती है वो एक कंसल्टेंट से दूसरे पे जाती है, वो कहता है उसने ठीक से नहीं किया, हम करते हैं, फिर उसने उसको छोड़ा, फिर वो तीसरे पे चली गई, उसने कहा हम बेटर करेंगे पूरा कंप्लीट, एंड इन दैट
इनकम्प्लीट है।
हाँ वी गेट लॉस्ट।
और दूसरी बात मैम, कीमोथेरेपी भी सर्जरी के लिए सब इतना 27-28 इयर्स यंग 3 डीएनसीज में नहीं हुआ तो दे विल स्टार्ट गोइंग टुवर्ड्स सर्जरीज मैम। मतलब कीमोथेरेपी इज आल्सो अ चॉइस, सोच के चलना चाहिए।
इज द फर्स्ट चॉइस, कीमोथेरेपी इज द फर्स्ट चॉइस,
राइट ट्रीटमेंट।
या
you know, conservative surgery is always, conservative treatment is always better as far as you can do it. So just to rush for the surgery is never advisable.
Dr. Meera has
एक एडवाइस उषा जी, आपको याद होगा एक मरीज आया था, 3 बारी डीएनसी हम लोग ने कर ली, बार बार वो ब्लीडिंग करके आता था, फिर अल्टीमेटली ये हुआ हिस्टोपैथोलॉजी करी तो उसका मोलर प्रेगनेंसी की डायग्नोसिस मिली। ये बात हमारे उसमें पीजी वाले में था, तब उषा जी हमारे साथ ही थी कि कितनी डीएनसी कर रही है, और बहुत वीआईपी पेशेंट था।
वीआईपी में ज्यादा ऐसा होता है।
डायग्नोज हुई थी।
बिल्कुल सही, मुझे भी याद है वो।
मैडम यही बस, that is what we wanted to
yes, it was very nice Kiran.
Kiran ma'am, can you stop share the slides ma'am?
Okay, I'll just stop it and I'll request Dr. Meera Agnotri were not there in the beginning, if she's there ma'am आप अपना कमेंट भी दें, ब्लेसिंग्स भी दें, और फिर आप लोग की सबके आशीर्वाद से हम लोग आगे बढ़े। मीरा जी इज देयर?
आगे नहीं बढ़े, कंक्लूड करें।
हाँ, कंक्लूड मतलब उसी के लिए फिर अपना मैडम इवनिंग टी साथ में लेनी।
एक्सीलेंट पैनल डिस्कशन,
बहुत बढ़िया,
थैंक यू।
देखो कितना इंटरेस्टिंग हुआ ना पैनल डिस्कशन। आप छोटी पहले टॉक रख लो 40 मिनट की, वो 50 मिनट तक बोले, वो भी बेचारा परेशान होता है कि बहुत देर हो गई, हम भी घड़ियां देखते हैं। तो it is very nice and I think everybody will follow this only panel discussion. I must congratulate you. Very nice subject and very nicely organized. जो cases थे बड़े अच्छे तुमने formulate करे और बहुत अच्छा।
Cases अच्छे थे, question answers अच्छे थे, बहुत बढ़िया।
बिल्कुल, बहुत interesting।
मैडम सबसे बड़ी बात है पैनलिस्ट अच्छे थे और एक्सपर्ट्स अच्छे थे।
ये तो है, पैनलिस्ट का तो कोई जवाब नहीं है, और एक्सपर्ट्स तो होते ही इसीलिए हैं।
जी मैडम, आप लोग।
और आई एम वेरी हैप्पी निशा, तुम्हारा गला बहुत खराब है, टेक केयर।
आई नो।
तुम आ तो गई वेबिनार में, पर रेस्ट करो।
जी मैम, इनपुट भी खूब दिया इन्होंने,
मुझे लगा आपने बुलाया।
वेरी नाइस, वेरी नाइस।
Thank you, Nisha.
Your presence was really precious, I must say, but take care because ये चीज बहुत दिनों तक तंग करती है।
जी सही कह रहे हैं,
रेस्ट लेना चाहिए।
थैंक यू मैम।
Thank you ma'am.
Thank you. Yes.
Thank you ma'am. Namaste ma'am.
Thank you ma'am for giving us an opportunity to do such kind of wonderful webinar in this platform ma'am, in this World Cancer Day ma'am. Beautiful topic ma'am, and delegates must be very much elated ma'am.
I think official thanks कौन दे रहा है?
मैम दिव्या मैम दे रहे मैम, so I will now like to call दिव्या मैम for the vote of thanks. मैम थोड़ा short and crisp रहिए, फटाफट।
बिल्कुल यार, बस
ऑफिशियल थैंक्स हो गया मैम। थैंक यू टू ऑल माय रिस्पेक्टेड सीनियर्स फॉर जॉइनिंग द वेबिनार।
मैडम बस मैं आई वुड लाइक टू से वन वर्ड कि मुझे ये बता दीजिए कि आप लोग, चंद्रा जी, आप, मीरा जी, आप लोग अभी भी कैसे इतना पढ़ लेते हैं? ये बता दीजिए।
कितना अच्छा बोलते हैं।
मैं बताऊं, मेरी पढ़ाई में हेल्प तो ये मेरी प्रियंका बहुत करवाती है।
ओके।
क्योंकि अब तो बहुत सी चीजें याद भी नहीं रहती हैं, तो रियली बट आई एम रियली इंटरेस्टेड, क्योंकि टू बी वेरी फ्रैंक 90 के बाद से मैं एडमिनिस्ट्रेटिव जॉब में हो गई ना, 1990 से, तब से लगता है तो बड़ा आउट ऑफ टच है, पर बीच बीच में इसीलिए थोड़ा कहीं सोसाइटीज में चले गए, कहीं चले गए, तो इंटरेस्ट
नहीं मैडम, आप अब बिल्कुल अपडेटेड हैं और ये मतलब हम लोग को लगता है कि अच्छा हम आपके समय तक कैसे इतने अपडेटेड रहेंगे।
वैसे तो बहुत कुछ थैंक्स गूगल को भी जाता है कि थोड़ा बहुत देखते रहो, पर मेरी तो असली टीचर प्रियंका है।
Okay.
I'm feeling embarrassed now.
Thank you, Kiran. It was
Thank you.
really
Thank you,
nice.
madam.
उर्मिला, सरोज, सबने, निशा, मैं रियली कहते किस किस का नाम लूं, सारे पैनलिस्ट वो वेरी नाइस। अमृता भी ने और शैली ने दूसरों के केस क्वेश्चंस भी ले लिए। इट वाज रियली क्रेडिटेबल। Thank you very much, Kiran. And I really
Thank you, everyone.
Thank you,
Thank you,
everyone. Thank you, Urmila.
और especially on World Cancer Day on such a upcoming topic. Very
good. Thank you, madam.
Bye bye.
Thank you, everyone.
Bye. Good night.
सबको मेरठ
Thank you, Dr. Anand. जी मैडम।
11-12-13 मार्च में मेरठ को आना है जरूर।
पक्का मैम, आएंगे भी और अपनी सोसाइटी को भी लाएंगे मैम।
I'm all the best, Dr. Kiran and Dr. Kanchan. All the best.
Thank you so much.
Thank you so much.
And my appeal for Dr. Sadhana Gupta.
We will support.
Yes, always, obviously. देखिए हम लोग को
They are very much
सबको
needed.
करना ही है। Yes, सबको करना है। Thank you.
सबको आना है, सबको वहीं मिलेंगे हम लोग।
जी मैम।
11 to